My name is David Lipschutz, and along with my colleague Scott Perkins, co-director here at the Center for Medicare Advocacy, it is my honor to kick off our annual Voices of Medicare Summit and to welcome all of you who are here in the room, those of you watching online, and those of you who might be looking at a recording later on. We had a little discrepancy in our recollection about what anniversary this was of our annual Voices of Medicare Summit, but we do believe it's our 13th. So we welcome you to our 13th annual Voices of Medicare Summit. So as we, and thank you, gentlemen, for your fix, because our slide actually said the 12th, but they were able to fix it, so thank you for that. As we gather today, our mistake, there are some milestones to celebrate, and as these numbers I am positive about. Last year, we celebrated the 60th anniversary of the Medicare and the Medicaid programs. And this year, we celebrate the 40th anniversary of the Center for Medicare Advocacy. Thanks in large part to our founder, Judy Stein, who is with us today, and everyone who's had anything to do with the center over the years. But while we celebrate these milestones, however, our critical healthcare programs and systems of support are under threat. Medicare is in our name, and we will certainly be talking about Medicare today, but we will also be looking more broadly at federal and state policy issues. Medicare does not exist in a vacuum. It is interconnected with other social insurance and adjacent programs, both in how it operates, the providers and stakeholders involved, and most importantly, the beneficiaries who rely on Medicare also rely on other programs meant to help them meet their needs, including Medicaid and Social Security. So our agenda today will be more broad. Our first panel, which I will introduce in a moment, will be talking about, among other things, the importance of social insurance. Our second panel will discuss threats to Medicare, focusing on privatization of the program. After a break, our next longer panel will address healthcare challenges and opportunities more generally, including the impact of H.R. 1, the so-called One Big Beautiful Bill. In addition to another break and a couple of Voices of Medicare, we will also have a short panel discussing the challenges of long-term care. And then our keynote Chitlin lecture will feature and honor Dr. Natalia Chalmers, who, among other things, will discuss the integration of oral and medical care. I want to thank in advance all of our presenters and moderators whose bios are in the program, our sponsors, and to thank all of you for attending. At this point, I'd like to start thanking our sponsors, which we will be doing throughout the day, by offering appreciation for the Christopher and Dana Reeve Foundation for their support. Now, to introduce our first panel on the promise of social insurance, which will be a moderated discussion between Rebecca Valles and Martin O'Malley. Rebecca is CEO of the National Academy of Social Insurance, otherwise known as NASI, and brings decades of experience shaping economic policy and social insurance, ranging from work as a legal aid attorney to the Center for American Progress. I think we were office suites at some point, briefly. Martin O'Malley's experience, extensive public service, includes time as the mayor of Baltimore, the governor of the great state of Maryland, and most recently, commissioner of the Social Security Administration in the previous administration. Rebecca and Martin, thank you.
Thank you, David. Thank you.
It is such a pleasure to be with everyone today, and just a huge, huge thank you to the Center for Medicare Advocacy for having us and for wanting to start this conversation and this day of conversations with really the why behind social insurance. It's so easy, especially in Washington spaces, to get right into the policy and the kind of technocratic debates and all that kind of stuff. And I know that a lot of that will come up today and needs to, but I know that and I have a hard time calling him governor because most recently to me he was commissioner, but Commissioner O'Malley and I often have these conversations. Why do we have these programs. What is, as he often puts it, the mission we share? And so that's really where we're going to start this conversation. And before we do that, I just want to say just happy anniversary to CMA. 40 years is remarkable. Thank you for your leadership over many decades. And I got to say, 1986 must have been a really good year, because that was the same year the Academy was founded. And we're doing our 40th shindig in just a couple of weeks. So I look forward to seeing many of you there. And we really look forward to toasting the Center for Medicare Advocacy and the launch of the new Aging and Disability Health Policy Lab later this evening. So nothing like starting off a panel by inviting you all for drinks on our rooftop at 5:30 this evening. Come by, come hang out. But Commissioner, you and I spent a lot of time last year marking the 90th anniversary of Social Security, 90 years of the New Deal. David also mentioned 60 years of Medicare and Medicaid. And maybe it's because I'm fresh off what's become an annual pilgrimage to the Francis Perkins homestead for me. But I'm thinking a lot about the origins of these programs, where they came from, why that amazing crew of Francis Perkins and FDR and all of those folks in the 30s really started that journey that we now call social insurance. When you think about the origins of Social Security, which you oversaw most recently in your position as commissioner of the agency, and programs like Medicare and Medicaid, what do you think about why those programs were founded and what they were fundamentally trying to say about who we are as a society?
Well, it's well. Let me thank you for having me here, and congratulations, David, on 40 years in the Bible. That's a long time. I'm sure it doesn't seem that long for you. And thank you all for your advocacy. Never more important than right now. A lot of times we think of advocates as people that move the ball down the field. Importantly, in times like such as these, that advocacy is making sure that that ball is not pushed back, into the safety zone. So as I think about the origins of this, I mean, it really comes down to the, fundamental core belief that we share as Americans, that we're all in this together, that we need each other, and that we have to help each other if we're going to succeed. And that succinct summation was from that great Marylander Frederick Douglass, and we had it on a big big image of a fierce Frederick Douglass up in the security stat room. And inside the room, we had FDR image and his quote, which was that our first principle is the security of the men, women, and children of our nation. And that's really the bottom line. Been watching a lot of... was watching up way too late, watching the Ken Burns series on Benjamin Franklin and the Constitution and that preamble, we the people. The mark of whether or not a society is a compassionate and caring society is how it takes care. I'm hitting all the great Americans now. How it takes care of those in the dawn of life and the dusk of life. It's really about every soul, and that's why I had such a gratifying, fulfilling experience leading the understaffed men and women of Social Security. The only reason they stayed was because of that mission that they all shared with all of you, that yes, we choose as a free people to feed the hungry, to heal the sick, to clothe the naked, to care for widows, and to care for orphans. That's who we are as a people. Ours is not some eugenicist view of human beings that somehow reach a stage in their lives where they are per se wastes because they do not contribute to the economic largesse of the captains of industry of the day. No, we believe in the dignity of every person. That's who we are as Americans. We oftentimes fall short of it. And, certainly no one understands that better than our black neighbors. But the fact remains, our North Star is the dignity of every person, and that's why Medicare is important. That's why Social Security is important, and that's why we cannot allow any temporary mortal to dismantle it.
As you're using some of that very moral based and in some cases even sort of spiritually based language, which resonates deeply with me and was deeply resonant for Frances Perkins at really the origins of a lot of this.
Saint Francis.
Saint Frances, who had her feast day in the Episcopalian Church just last week, for anyone who is also a Frances Perkins fan and nerd.
Or an Episcopalian.
Or an Episcopalian, either, or both, possibly both. But when I hear you describe these programs in those terms, it really it brings me back to one of the ways I think about the moment that we're in, and I wonder how much this resonates for you. A lot of folks are understanding this particular moment, which is a challenging moment, which is a moment of retrenchment, which is a moment of real revisiting and reviewing even our very social contract. It feels very much, I think, to a lot of people like we're in the middle of a battle of imaginations about what kind of society we are choosing to be, that's what underpins debates over solvency, right? A very arcane sort of DC term, which really is about what kind of society are we choosing to be. Talk to us about how to show up in this moment, what it looks like to show up in this moment, yes, to hold the line, as you were describing, but also as people connected to that North Star who are ideally aiming to hold that vision of what kind of society we could choose to be.
So much of what we're going through right now is, to your point of a battle of imaginations. Most Americans have a much easier time imagining a future of less than they do imagining a future of more. And by more, I don't necessarily mean, more in your bank account, although that's a piece of it, especially if you're just getting by day, and cost of living is outstripping the COLA on your Social Security benefit that you entirely live upon. But this, I think part of what it means to show up in this moment, Rebecca, is to imagine that future where there's greater health and greater prosperity, and especially greater well-being for all. I mean, for a long time, I believe that those of us in the Western mind, European, American, etc., equated increased consumption with increased happiness. And they're not the same thing. But all around the globe, I think you're seeing a displacement of that worn-out theory of, more is better, more and more and more and more and more. Instead, it's being replaced by well-being, health, well-being of the whole. And our children understand that in the emergence of this third ethic, the ethic of the earth. They understand it very, very intrinsically, intuitively. But we are trapped in this battle of scarcity. And when tomorrow is inevitably going to be worse than today, people turn on each other and resort to tribalism, and the authoritarian is going to preserve your tribal lifeboat in a tomorrow where there's less. And so part of what it means to show up in this moment, I think, is to with a smile and with honesty and integrity, say we live in a time of enormous opportunity. Never before as a species have we had the technology and the know-how to create a tomorrow with greater health and well-being for all, for more people rather than less. A third American century, a fast-moving third industrial revolution. We need to embrace the moment. I was in China after the first election of Donald Trump, and the guy on their Politburo, who was the head of international relations, said to me, "Let me ask you a question, Governor, since you were out there." He said, "How is it that Americans seem to have become so afraid of the future when that runs contrary to everything we thought we understood about the American character?" That's the real deficit we confront. It's not about making the math work, it's about making our hearts and imaginations work and putting forward that vision that, in fact, tomorrow can be better than today. And there is no people on the planet that have more power to make it so than we.
So, with that forward-looking perspective, and I know you've got a couple of slides that you want to show.
You said that with a scolding. Didn't she have a scolding tone?
Well, I think anyone who knows me and knows what kind of conferences I like to run, I usually ban PowerPoint, but you get an
It's
exception.
not a PowerPoint, it's 2 slides.
I'll allow it. So for the 2 slides you want to show, I'm going to tee you up to talk a little bit about this by asking, you are out there in a lot of settings right now, really kind of, yes, preaching the gospel of Social Security, but talking about how misunderstood the future and what's possible within Social Security really is. And a lot of that is, a lot of misinformation that gets pushed by folks who want to cut it, who want to dismantle it, who are those kind of austerity preachers, as you were describing. And so we are in the middle of a conversation that's only going to accelerate in the coming years around what do we do to secure the future of Social Security. And you've really been out there helping people understand that it's actually not all that difficult to address. Talk to us a little bit about what you see for the future of Social Security, what the American people want, and some of what you've been out there helping people understand.
Yeah, this is a great time because we're at a moment as we face the so-called cliff, or that moment of insolvency in 2033, where Social Security will not be able to pay 100% of benefits, only 77 or 80% of benefits. So that creates an action-inducing event for a legislature, and they tend not to act unless they're induced, and deadlines have a way of doing that. So right now, every person running for the United States Senate is going to be in office when either they let that cliff hit people or when they come together with an enormous consensus among Americans to actually strengthen Social Security and make it better. How about this? In a time of deep division and polarization, 87% of Americans actually want Social Security to be strengthened, made better, want benefits increased, and want it to be there for their kids and grandkids. And so that's an enormous, that's why this is such a great opportunity right now for us to advance this conversation in our own tables of democracy. And I know we're a little bit preaching to the choir, but as Dr. King said, it's important to preach to the choir, otherwise they stop singing. So as I do town halls on this issue, in addition to busting the big lies of the zombie apocalypse, 12 million people getting checks from Social Security after they're dead. It's not true, folks. Total bullshit. Audited every year. Doesn't happen. But 2 of the big myths that all of these scary headlines have kind of ingrained to us. One of them is that it's a Ponzi scheme. It's going insolvent. It's going bankrupt. It can't be fixed. It's inevitable. It's going to happen. The other one is, well, the customer service is bad, but it's always been bad. Au contraire. It has not always been bad. Actually, there was a time 12 years ago when that agency, according to the Federal Employee Viewpoint Survey, which we've stopped doing because we don't really care to have the viewpoints of the people doing the jobs, when they listed themselves one of the best places to work in the federal government, that over 10 years of benign neglect and some would say malignant intent, Social Security staffing was reduced to a 50-year low, while us baby boomers swelled their ranks every day to a new all-time high. And so, and get this, when they operated well, they operated only on 1.2% overhead for the benefits they paid out. You know what Allstate's ratio by that measure is? 19%. You know what Liberty Mutual, Liberty Biberty is? It's 23%. Now they're struggling to operate on about 0.7% overhead. So no wonder you have, once again, hour-and-a-half wait times on the phone and all of the horror stories that your own networks tell you about. So first slide, Mark. And this is the slide you can't unsee. The blue graph is us, we the people becoming active beneficiaries. And that red line is staffing. Where you see it take a nosedive, that's the Trump administration, Elon Musk, Doge, who actually took your money and paid your employees to quit if they'd quit in March and not let the door hit their ass on the way out. It's probably even worse than that now. When I was there, we thought the fire-breathing dragon threatening the agency was a high attrition rate from, burnout. These guys think that it's great to have a high attrition rate. Leave, leave, leave. So the solution here is, if Congress wanted to, they could take, right now, it's about 75% of Social Security's overhead is taken from the same trust fund dollars we put in, working people and contribute. They could take it all and take the agency back up to 1.2%. They could take it all from the trust fund and do that, and it wouldn't advance that depletion date by any more than 30 days. So why are we doing this to ourselves? There is a solution, but the solution isn't going to come from, selling the Woodlawn campus to the highest bidder. Next one. Next slide. This is on the solvency thing, so-called. And it's so ingrained, it's even hard to talk about it. I've tried to come up with a better phrase, like guaranteeing Social Security will always be able to pay 100% of benefits earned. Because the truth is, any of us, when we talk about solvency, if you had a company in the small business you run, and your sister-in-law that does your books told you that you're going to have a 20% shortfall in revenues in 2033, you wouldn't immediately rush out, slap a going bankrupt sign over the front of your business. No, you'd make adjustments. And every 30 years or so, Congress makes adjustments. That's what they did in 1982. But I asked, once I was confirmed, I asked Steve Goss, the long-serving actuary, I said, what did you all get wrong in 1982 such that we're having this depletion event in 2033 now instead of 2050 like you thought? And you know what his answer was? It wasn't longevity. It wasn't birth rates. It was income inequality. He said, we thought, prior to all the other things that Ronald Reagan did in the remaining 6 years of his 8, to suppress wages, which then, flatlined for 90% of us for the next 40 years. That wasn't the way the economy worked prior to that time. He said, we were asked to set a cap on the income to which Social Security's tax would be applied, and to set that cap at such a rate that it would capture 90% of increased earnings for the next 40 years. But with the changes to the tax code and the economy, and only the highest earning people actually seeing appreciable gains, we only captured about 82%. So that's why that surplus reserve intended to cover, the baby boomer demographic bulge is running out sooner than we thought. So there's an increasing phrase that more and more people understand out there in America, and that is to scrap the cap. Why is it that a family making $182,000 and paying $11,000 into Social Security, that $11,000 is the same amount that a single man making $182 million pays into Social Security? And most Americans think that's not fair. So this graph is from the John Larson bill and the scoring on it, which shows that you could actually increase benefits, CPIE, the cost of living for elderly people. You could increase, the base sort of amount, and it would extend the ability of Social Security to pay 100% of benefits into the far future, 2090. Anybody planning your future on 2090? So the solution is there. And get this, recently, very recently, this is my last point on this, recently, and no more slides, a senator named Bernie, not that one, in an open hearing said, I just don't understand why wealthy people shouldn't pay the same rate as everybody else into Social Security. Bernie Moreno, Republican senator from Ohio. So, and having met with many of these folks, both sides of the aisle, as part of the confirmation process, I know that to the extent you know anything in American politics, so that's a big disclaimer, but my gut tells me there is some pretty broad-based art of the deal out there for scrapping the cap at a certain income level to solve this problem for the far future. So that's the bottom line. Look, the customer service thing, the ability to pay 100% of benefits, solvable problems.
And just to say, because you've laid it out beautifully, Commissioner, and you've promised to have no more slides, so now I'm just giving you a hard time. They were good slides; they were worth it. But I think just to put an even finer point on it, because what you're identifying, right, is not just something that has had one Republican member of Congress agree with it. When you ask the American people what they want from policymakers in Washington for the future of Social Security, this is exactly what they say, and that's not just folks who are progressive, it's folks across the political spectrum, folks across the income spectrum, even the wealthy say, yes, this makes really good sense to me.
And that's what's made them back off from some of the deeper harm that they set out to do. They wanted to cut, they said they were going to cut 50% of the IT staff at Social Security. And when some of us rang alarms and said that would interrupt benefits, including Mike Astrew, George Bush's commissioner, said they're going to put benefits at risk if they cut 50% of the system staff. They backed off of that and actually rescinded, the pay to leave sort of incentives that some people in IT had taken. And then the paper check thing, they said they weren't going to send paper checks to the 500,000 people that elected to receive their benefits that way. When the democracy, that broad-based coalition you talked about, roared back, or consensus rather, they backed off of that. And then the mega reg, where they would have shoved 50% or 40% of people over the age of 50 off of disability rolls, they backed off on that. So the good news is the Trump administration politically understands that this is a huge vulnerability for them. You didn't hear him talk about all of the big lies about, you didn't hear him talk trash about Social Security in his second State of the Union, did you? That's because Americans want them to strengthen it, not to weaken it or privatize it.
Well, and I feel like we've given you guys a good set of food for thought before the next trustees report comes out, because that's on Social Security and Medicare, and that will be fairly soon. But people know what they want Washington to do, right? And it is really, it seems like we're in a moment where people can't agree on anything, but this is something that people agree on. And it is worth remembering that, given that that sort of defies the conventional wisdom in Washington sometimes. So, Commissioner, I want to close out with just sort of a higher level forward-looking question for you. I mentioned, I disclosed, I've been thinking a lot about the origins of these programs. And one of the quotes that sticks with me, and I'll give this one to FDR instead of to Frances Perkins, because I could do all day on Frances Perkins, and she deserves that, but FDR deserves a little bit too. When he was signing the Social Security Act in 1935, that big New Deal moment, he called that program a cornerstone in a structure which is being built, but which is by no means complete. And in a lot of ways, even though we're 90 years plus on the other side of that, it feels like that's still true, right? We still have huge gaps in our social insurance system, even relative to what FDR and Frances Perkins were talking about 90 plus years ago. Things like long-term care, right, which I know is going to come up later today and is still really a huge hole for probably many people in this room personally affected by that in one way or another. And so as you think about this moment that we're in, where we're facing, yes, action-forcing events on Social Security, on Medicare as well, but also, retrenchment and this challenging moment politically, how should we think not just about preserving what we already have, but continuing to build on that structure that's by no means complete?
Like paid family leave and those other things. I was in Nebraska recently, and a gentleman said, why don't we use Social Security as the platform to make sure that college is affordable for all? And of course, I was kind of gobsmacked by that, only because I hadn't had the imagination to think of it. But as I kind of unpacked it on the plane, it's like, you know what? There's probably not a logistical reason or any reason of math or technology that would prevent us from doing that. So to imagine that how this program can be strengthened, the long-term care, the paid family leave, perhaps even as all of the concerns about AI and how that will change the economy comes up, there is waiting to be born a story about what that next chapter of Social Security is beyond just better cost of living increases. And that's this moment. I think it is the long-term care. and I think it is the paid family leave, and perhaps other things as well. Certainly, changes so that people aren't penalized when they take time away from work, and oftentimes it's the women in the family that do this to take care of an elderly parent or a sick child. But that's the Magis. We were talking Jesuit Volunteer Corps stuff earlier. Magis, that's the greater, and that's certainly a critically needed vision for what we need right now. It's not just about preserving what we used to have. It's about creating more.
So I just will close with some words from a spiritual mentor of mine, which some of you maybe have heard me share at different points and in different settings, but it's what I think about every morning when I wake up, because these are not easy times to do this work. And those words, which were shared with me early in the pandemic, but which I feel are truer every single day than the day before, is that living at this time in human history is either an affliction or it's an assignment, and it's up to each of us to choose the assignment. That's what I wake up thinking about every day, and I know that that is true of every single person in this room, choosing the assignment. That's why you're here. It's why you're still showing up doing this work. A lot of gratitude to you, Commissioner, for your continued leadership, and a lot of gratitude to the Center for Medicare Advocacy for your continued leadership. And I know that the rest of the day's conversations are going to be the right ones for this moment. Thank you.
Thank you all. Thanks.
Thank you so much, Rick. Thank you. Thank
David,
you, Governor
thank you.
O'Malley. Thank you. Thank you, Rebecca and Governor O'Malley. You have indeed given us a lot to think about. Before starting this next panel, I'd like to thank a couple more of our sponsors, AARP and Mansfield Family Practice, for their support today. It's very much appreciated. Now joining the stage, we are lucky to have a repeat guest to our summit, Wendell Potter, one of our nation's foremost healthcare reform advocates. Wendell was a former health insurance company executive, turned whistleblower, turned advocate, and someone who I am proud to call both a colleague and a friend. Now, there's much to celebrate in the history of Medicare. It helped reduce poverty amongst older adults, played a key role in integrating hospitals in our country, and has played an important role in the economic security of tens of millions of people. But there are also shortcomings and challenges that face the Medicare program, including gaps in coverage, challenges with affordability, and sustainability of the program. Some of this has been exacerbated by H.R. 1, the one big, beautiful bill that will be touched on, I think, more in an upcoming panel. One major storyline of the Medicare program has been the rapid growth in enrollment in private Medicare Advantage plans over the last 20 years. It's gone from 19% of the population to over 50%, about 54%. So what we want to focus on now, in our time together, is the privatization of the program, what that means for Medicare beneficiaries and the program as a whole. So starting with Medicare beneficiaries. As an organization that represents Medicare beneficiaries, we know and run into barriers in the traditional Medicare program all the time. And that ranges from improper use of the so-called improvement standard in order to get coverage in certain care settings, or the diminishing of the Medicare home health benefit, and particularly home health aides. And on the one hand, while people in Medicare Advantage have access to some services that traditional Medicare doesn't cover, on the other hand, there are also additional barriers that people in Medicare Advantage face that those in traditional Medicare largely do not, which include things such as prior authorization and network limitations. So let's start with talking about those two. Prior authorization, what is it meant to do? Does it really work? Does it help contain health costs, or does it deter medically necessary care?
Well, it does both, actually. Prior authorization, at least conceptually, is to reduce unnecessary and maybe harmful care. It has been used by big insurance companies as they have gotten more and more in control of our healthcare system and have a need to make more money for their investors. has become a big tool to deny necessary care, and it's demonstrated. We've seen a lot of data that shows that big insurance companies that operate Medicare Advantage plans make an inordinate use of prior authorization, more in Medicare Advantage in many cases than their commercial health insurance plans. It is a tool that they are using now to try to make sure that they are staying in the good graces of their investors. Now, not all health insurers that participate in the program are for profit, but by far the dominant players, United Health Group, Aetna, Elevance, which owns many Blue Cross plans around the country, Humana, where I used to work. They dominate the business and make great use of prior authorization as one of their means. I often say it's kind of a dial, or it's one of their levers that they can use to adjust when they are faced, as they have been in recent quarters, with rising medical expenses. They will ramp up their use of prior authorization to control or limit the access to healthcare goods and services. There are actually kind of two ways to control or manage or bend the cost curve, if you will. One is to have an influence on the unit cost of healthcare goods and services, and the other is the utilization of goods and services. And health insurance companies have certainly focused almost all of their attention on the latter. In fact, they don't care as much about controlling the unit cost of goods and services because as those costs go up, big insurance companies just calculate what medical trend is, and next year ask or demand that their customers pay more in premiums. So it's a way of maximizing their revenues. So they focus on the other end of trying to reduce medical expenditures by reducing the care that people need. And in many cases, the care that is denied or delayed is medically necessary care. And few people know that they have the ability to appeal a denial, and as a consequence, they're not getting the care that they need. And the companies are pocketing money that they shouldn't be pocketing.
Right. And so we know from KFF, maybe data generated in this very building, that, as you mentioned, few people bother to appeal
Right.
when they face denials. But among those who do appeal, they tend to be pretty successful,
Right.
which suggests that there's an awful lot of care that because the first levels of appeal of Medicare Advantage usually go right back to the insurance company themselves. There's a significant level of denials that are happening that even the insurance company disagrees with on the front end.
Oh,
So what does that look like for a consumer?
It's daunting. Keep in mind, too, that when you are needing care and you're faced with a prior authorization, you're probably sick. You're not well. You may be older and not aware of how to even begin to approach appealing a denial. And if you don't have someone in your family or in your network to help you, it's really daunting. It's almost an impossibility to navigate that part of the healthcare system, or even to know what your rights are. Very few people even have an understanding of their ability to appeal. Insurance companies know that. It's kind of baked into what their revenue and profit expectations are. They know that a very small percentage of people, for one reason or another, will appeal a denial, and consequently they go without the care that they need.
One phenomenon related to prior authorization that we're trying to bring more attention to is instances in which care is initially approved, but then it's prematurely terminated. We see this most often, I think, in like skilled nursing facility or home health settings where there's no question that someone needs some care in a nursing facility for a little while. Clinicians say a person will need 3 weeks, but a week later, the Medicare Advantage enrollee will get a termination notice of coverage. And of the people that bother to appeal, we have seen multiple repeat denials in the same episode of care. 2 times, 3 times, 5 times, 10 times in the same episode of care, skilled nursing facility stay, where people, as you say, they're in a medically vulnerable situation. They keep on getting denials and are forced to appeal and win those appeals. But eventually, break down. Either they get the care that they need or they give up.
It's a huge. In fact, my own family, my mother experienced that. I had been an advocate of Medicare Advantage in my career in the health insurance business. In fact, I joined Humana not long after the Center for Medicare Advocacy was formed in the late 80s. And I saw at Humana how profitable the Medicare program is for these companies. But I also saw firsthand what it is like for a patient who needs care, who needs skilled nursing care. My mother broke her hip. She was in a Medicare Advantage plan. And I had encouraged mom and dad to do that, to enroll in one, not even thinking what would happen when they really needed their plan. Well, she needed skilled nursing care, and a utilization review nurse was constantly looking at whether she was responding to the care that she was getting, whether she needed further care. And like you said, she and many, many other beneficiaries who are enrolled in Medicare Advantage plans find that they are denied the care that they need in skilled nursing facilities, completely different from the experience that someone would have if they were in traditional Medicare. There's always someone on behalf of an insurance company who is monitoring the care that a person is getting and not necessarily basing those decisions on need by any means.
So now, unfortunately, we have to add a little asterisk to the point about people in traditional Medicare not generally facing prior authorization. Because we've seen now with this WISER demonstration that's going forward in about 6 states, where right now very few services are subject to prior authorization in traditional Medicare. But this model expands that list and is employing some of the very same vendors that Medicare Advantage plans use to make determinations of coverage, employing AI or algorithmic tools, and those vendors have a financial incentive to withhold care because they get to share in the so-called savings. Could that corrupt the traditional Medicare program if that's...
No, absolutely. It's kind of the nose under the tent as a way of getting in there, and I think the intention certainly is for that to expand to a much broader set of services that a person might need. And I think it's as you noted, the model itself is designed for corruption. And if the entities that are involved in this, and many of them, it's hard to even find what their track record is or what they have done in the past, but they do have associations with and sometimes are part of these big conglomerates that I write a lot about for the newsletter. But they have, it is in their financial interest. They make more money when they deny care because they capture a percentage of the so-called savings.
Yeah. So where we sit as an organization that provides services for Medicare beneficiaries, the people who contact us are pretty self-selective, right? They don't call us when their care is particularly well coordinated and when they have wonderful experiences with their plans. But I think it's pretty undeniable that there are barriers to care through private Medicare Advantage plans that don't exist in traditional Medicare. What about the impact of the growing privatization of Medicare on the Medicare program itself? You alluded earlier to payment that Medicare Advantage plans get paid. Can you talk a little bit about that?
Well, it's a very, very lucrative part of a health insurance company's book of business for most of them. I follow the earnings reports for the big companies every quarter. One of my responsibilities when I was at Cigna was handling financial communications for the company. I did for 10 years, so I became obviously very familiar with the earnings reports. And I've noticed just how much Medicare Advantage contributes to earnings for these companies, and it's significant. United Health Group, for example, United Healthcare, the insurance arm, gets about 77% of its revenue now from public programs, even though it is the largest insurer, the largest commercial insurer, has far more people enrolled in their commercial plans. It gets way more revenue from the public programs, and it is because of the way that they've been able to manipulate the risk scoring system and other ways of overcharging the government. So it's extraordinarily profitable. Now, the companies have had some problems on Wall Street. They're continuing to be profitable, but from investors' points of view and Wall Street financial analysts, not profitable enough. So they've had a hit with their stock price. And so now they are pulling some of these levers to try to improve their profit margins and their return on equity. And that is really affecting beneficiaries in ways that most beneficiaries wouldn't have any idea is happening. But we will see and are seeing an uptick in the use of prior authorization, even as these companies are pledging or saying and telling the administration that they're voluntarily reducing the use of prior authorization. There's no way of auditing that, to making sure that they're good on what they're saying, and I certainly don't believe, I wouldn't take them for their word at all. But they're out there with their public relations campaigns to try to get people to think that they're doing that. But the other things that they're doing, they're reducing their networks, the composition of their networks, and a lot of healthcare providers are voluntarily dropping out because they're complaining, and I think justifiably so, of not being reimbursed adequately by insurance companies. Some of the major hospitals in the country are dropping out of managed care networks or Medicare Advantage networks. Others are being dropped involuntarily, and physician practices as well too. So the provider networks are shrinking for many of them. They are also exiting a lot of markets. This past year, I think about 4 million Medicare Advantage beneficiaries had to scramble to find another health plan because their insurer exited those markets because they deemed that those markets were not as profitable as they wanted them to be. So they just cut people loose. And they also are reducing, in many cases eliminating, their PPOs. And in many markets, the only thing you can find is an HMO, which has a much more restrictive network of providers. So they're doing a lot of these things, and they are not required to disclose any of this in their advertising. It is not anything like what even drug companies have to do. Drug companies in their advertising at least have to have someone speed talk through what the side effects are, but you don't see any of that in the Medicare Advantage plans. And of course, traditional Medicare does not and cannot advertise. So traditional Medicare largely has its hands tied behind its back when it's trying to compete with these big companies that are able to go out there advertising the so-called extra benefits they get and obscure the downsides of enrolling in these plans.
I think that's a really important point. One refrain I hear amongst health advocates often is that traditional Medicare doesn't have its own lobby.
Right.
There are a few people out there pushing to preserve and protect traditional Medicare. And now, because of the way the program is structured, people have to essentially purchase a private plan. If you want prescription drug coverage, you have to purchase a private standalone Part D drug plan. Or if you can afford a Medigap policy, you have to purchase a separate standalone Medigap policy. Many of the same companies that offer Medicare Advantage offer those plans too. But as you noted, it's far more lucrative on their Medicare Advantage side. So Medicare Advantage is costing the Medicare program more per beneficiary, right? MedPAC, the Medicare Payment Advisory Commission, which might be a relatively conservative estimate, says that in 2025, Medicare paid $76 billion more for Medicare Advantage than traditional Medicare would spend on the same beneficiaries, in part due to manipulation of the risk-adjusted payment system and quality bonus programs that don't really improve quality or measure quality. And that costs more for everybody, including increased Part B premium. You've done a lot of work exposing the practices of insurance companies. How do they maintain this status quo? I mean, you made a reference to this administration saying it's cracking down on prior authorization. We've heard things being said about, attacking overpayments. But how does the insurance industry maintain this? And what does that mean for Medicare in the long run?
Through armies of lobbyists. And you're right, traditional Medicare doesn't have anything close to the representation on Capitol Hill that these companies do. campaign contributions. One of the things that my team and I have just launched is a tracker looking at how much these big companies are donating to candidates and members of Congress. And it's astonishing when you look at how much money they are. Well, actually, you don't have to spend a lot of money to buy influence in this town, but they spend enough money to buy considerable influence to keep the status quo going, to keep that cash cow alive, and public relations and advertising. They spend enormous amounts of money. I know this because I was part of that machinery of working through public relations firms and advertising firms to persuade people that Medicare Advantage plans are superior, again, to obscure the things about Medicare Advantage that the industry does not want people to know until it's too late, until they're trapped into one of these plans and find out then, this is what I wish I had known back then. But it is, they spend so much money. But they're making so much money. What they spend on campaign contributions and in lobbying is the cost of doing business, but it's actually a pretty small percentage of what they rake in from the government. And you're right, they're able to get overpaid. The promise for privatizing Medicare was that it would save money, save beneficiaries and the program and the country taxpayers money. It has never saved the company or anybody a dime. They will argue that it's beneficial to Medicare beneficiaries, but they pay, taxpayers pay more for every enrollee in a Medicare Advantage plan than someone who is in a traditional program. So it was the idea, the belief was that private companies can do a much better job of administering benefits and managing the program, but it was based on false premise, and it was never going to happen because, again, mainly because of the way that these big for-profit corporations were able pretty quickly to take the program over.
So in a recent column you wrote for Healthcare Uncovered, your blog, which is excellent, argued that health insurance is a market failure.
Yeah.
Can you talk a little bit more about that and what you meant by that?
Well, when you look at other sectors of the economy, in fact, I was recently invited to testify, of all places, in Austin at a House hearing on healthcare affordability, and I made the comparison of looking at the automobile industry. Ford, for example, and by the way, you can buy a brand new Ford for how much it costs now for a family premium in this country in the employer space. About $27,000 now is the average cost of a family premium. But the premiums go up every year. The cost of a Ford goes up every year, but at least you can have some expectation that the car will probably be safer, it'll look a little bit cooler, it'll have some bells and whistles, it'll be something that you are getting some additional benefits. It's the exact opposite in health insurance. Plus, there's no ability, there's very little transparency. You don't, consumers are not equipped with the information they need to make informed choices. The industry has always said that we need more transparency. They say that, but behind the scenes make sure that there is not transparency. They benefit from the complexity and the confusion that people face in insurance. So it just does not have the elements that a functioning industry that is benefiting consumers has. It fails consumers because we don't have that transparency, and we are constantly paying more and getting less value. And there's a term for this in the industry. It's called benefit buy-down. And I never use that with reporters, but that's what executives talk about behind closed doors. This is, and with analysts, this is what has happened. We always are raising premiums, again, back to anticipating what medical trend is going to be, but to try to make sure that we are also capturing more of that money, keeping more of that money, being able to reward shareholders with the premiums that we take in, will reduce the value of the coverage in some way. And it can be higher out-of-pocket costs, which are exorbitant in commercial plans. even in Medicare Advantage, there is a limit on how much you have to pay out of pocket. But if you are in an HMO or a PPO and go out of network, you're going to be faced with paying a lot of money out of pocket. The use of prior authorization, the limited networks that I talked about. These are all ways that these companies are devaluing a healthcare policy, and we're not able to have the information that we need. I was part of the effort back 20 years ago to create the impression, the belief that what we needed in this country was consumer-driven healthcare. That if we gave people more skin in the game, but also the tools to be able to shop for healthcare, we'd be off to Nirvana. We'd problem solved. It was never the intention for there to be adequate transparency or to give people the tools that they really need to make these decisions. It was never intended. It was a good talking point. I even believed it myself for a while until I realized that I was telling people a lie. One of the reasons I left was because of the industry-wide effort to move as many of us as quickly as possible into high-deductible plans, because it gets these companies off the hook from paying for care that they otherwise and had recently been paying.
And so what you just outlined is pretty much the way that our entire healthcare system works.
It is.
Reliant upon private plans.
Yeah.
All that's available through the Affordable Care Act structures. Vast majority of Medicaid is only available through private plans, and now we cross that threshold in Medicare with over 50%
Right.
of people in private plans. So what is lost as traditional Medicare in turn diminishes?
Well, we're not completely thrown to the wolves yet because of the existence of the traditional program. If it withers on the vine, as some of the advocates for privatization of the program hoped for and even said out loud in the early days of the movement to create the modern version of Medicare Advantage. Prior to the 2003 Medicare Modernization Act, there was a private version. It was called Medicare Plus Choice, but that law was put into place that made it much more lucrative for private companies to participate in the program and to do what they're able to do to overcharge the government to capture all these extra billions of dollars. We lose the ability to keep from overpaying. I mean, as fewer people enroll in traditional Medicare, more money is going to these companies, and we as taxpayers are losing out on that because it is not going to ever save the country money. It is just not. It is not in the cards to do that. But for beneficiaries, they're losing a choice. They're losing an option that many people really do value. Even with WISER, the majority of goods and services are not subject to prior authorization. That will change. And if it's already beginning to change, as you noted, in traditional Medicare, let's hopefully that can be halted and not go further, or maybe not even be continued. But I think it would require a change of administration for that to happen. But we just lose the ability also as a benchmark of determining how much Medicare Advantage plans should be paid. It is based on the traditional Medicare program in certain ways in terms of compensation to providers. You lose a lot as that diminishes.
So in traditional Medicare, it seems like it would be safe to say that we rely, for whether or not health care is going to be provided, we rely more on clinicians' judgment.
Yeah.
And in insurance-driven healthcare, you rely more on insurance company judgment, which ostensibly includes clinicians. But traditional Medicare, you can see whatever provider you want. You're largely not subject to prior authorization. But it seems there are other things that could be lost as traditional Medicare withers, and there's some things that in which Medicare program leads the way in the healthcare system, right? It's setting quality measures and standards,
Exactly.
supporting graduate medical education, supporting rural providers, that as the system becomes more privatized, it's fading.
Yes. and will continue to fade and vanish because these big companies have no interest in continuing any of that. It is all about making money for shareholders, and I keep talking about shareholders because, again, the big players are these for-profit entities, and whether we're talking about Medicare Advantage or the commercial plans right now, the things they're doing, and they're saying this out loud to investors, they don't say this much on Capitol Hill, that they're doing to control medical expenses is to reduce the composition and size of the networks, ratchet up utilization management tools, make people pay more out of pocket. The out-of-pocket costs go up every single year. I mean, one of the things I established a couple of years ago is the Lower Out-of-Pockets Now Coalition, because out-of-pockets is just, the reason, we have 100 million people in this country who are saddled with medical debt. The vast majority of those folks have health insurance. They just cannot afford to get the care that they need without spending a lot of money out of pocket. And it's often money they don't have, so they go into debt because of that. Or they don't get the care that they need. That is a reality for a lot of people in commercial plans, and that is increasingly, I think, going to be the reality for people who are in a public program as well.
So what can policymakers do to rebalance things between traditional Medicare and Medicare Advantage to so-called level the playing field?
Yeah.
What can be done policy-wise, do you think?
A lot is follow the recommendations of MedPAC, and I've talked to some of the commissioners, and I know they're dismayed that a lot of the reports that they send to Capitol Hill and just ignored do something about the overpayments, for one thing. You've got the No Upcode Act. One of the chief sponsors was Senator Cassidy, who will not be in the Senate very much longer. But it is a bipartisan bill. But that's one thing. Addressing the overpayments is really, really important. I am seeing bipartisan interest in addressing prior authorization. Some of the members of Congress are physicians who see this and have seen it in their own practices and hear from their constituents what a burden that is for providers as well as for patients. There is some interest in addressing out-of-pocket costs to do things that would save people money and enable them to get the care that they need. But there's not enough, I don't think, attention focused on the problems of Medicare Advantage for beneficiaries and for taxpayers. We're seeing that change, and I think that is a consequence of the work that you all have done and that many of us have done in advocacy on the Hill, of just raising the awareness of the things that we've talked about. So I am seeing more attention focused on that now than I would say 5 years ago, for sure. But it takes a lot of effort, as you know, a lot of meetings with staffers and just trying to compete with those many lobbyists for the companies that are always present and have entree because of the campaign contributions their companies make.
So as long as we have private plans in Medicare, we need to adjust payment.
Yes.
We need payment parity. We need an out-of-pocket cap.
Right.
We need to allow traditional Medicare to cover some of the things that Medicare Advantage can cover, vision, hearing, dental. And as long as we have private plans in Medicare, we need far greater and meaningful oversight
Yes.
to make and hold plans accountable for more than just the cost of doing business.
They really need to be held far more accountable. And you're right, the traditional program needs to be updated. It needs to have, from here on up, we need vision, dental, and hearing benefits.
Yeah.
The program was created in the 60s and hasn't changed a lot. It doesn't have an out-of-pocket cap. We need that too. There are some things that would really be of great value to beneficiaries. So it needs to be improved and I think expanded as well too. It's a program that works very, very well, has far lower administrative cost, is much more fair, and doesn't rip off taxpayers anywhere. The taxpayers are really being ripped off by the private companies. You're not seeing that with the traditional program.
So in closing, trying to draw some of our energy from Governor O'Malley's call to us to strengthen our resolve to protect the public programs and envision a better future. Do you have any closing thoughts on how we get there with Medicare or healthcare more broadly?
Just keep up the advocacy. The word advocacy in your title is absolutely essential. And we need to bring people together and help educate advocates to understand how they can be more effective in their advocacy. Try to expand that choir. It's important to, again, preach to the choir, but expand the choir to get more people to understand. That's why I started the Healthcare Uncovered newsletter, because a lot of what we're talking about now is just not adequately covered by the media. There's not very much of awareness of much of what we've talked about during our time together here. We need to educate the public and lawmakers too. You know as well as I do, if you're on Capitol Hill, you find that the understanding of the healthcare system, even those who are on committees of jurisdiction, is often pretty shallow. And about the only information they get day in and day out is from the lobbyists for the companies that also were able to give them campaign contributions. Advocacy is very essential. Figuring out ways to educate the public and the media to try to influence how stories are covered, are reported, and to make sure that this is something that people are aware of, and to work to try to keep more people from unwittingly being moved into Medicare Advantage. A lot of people, as you know, are being moved against their wishes, sometimes because their employer, whether it's a corporation or a municipality or a state, will just move people into, if they're retirees with benefits, retirement benefits, into Medicare Advantage plans. So a lot that we need to address. A lot of work to do.
That sounds like a good place to start. Wendell Potter, thank you so much for your time today.
Thank you. Thank you. Thank you.
So for those both here in the room and watching online, we're going to enter a 30-minute break. So go grab a beverage, enjoy yourself, and we'll be back shortly. Thank you. get started again. Welcome back from the break and welcome to our next panel, Healthcare Challenges and Opportunities. Our dear colleague Kata Kertész, Managing Policy Director, has worked hard to put this panel together and was set to moderate it, but unfortunately had to attend to a family emergency. As part of our ongoing efforts to thank our sponsors, at this point, we'd like to thank Justice in Aging and the Rothkopf Law Group. I'd also like to thank all of you, all of the panelists, but in particularly Tim Engelhardt for agreeing to step in as moderator at the very last minute. So he's very skilled at this, but if he messes up, is flustered, blubs.
Thank you for lowering their expectations.
Yeah, just know that he is doing us a service and filling in at the last minute. Thank you, Tim. I can quickly introduce the panelists and then let you take it from here. Tim Engelhardt from the Aging and Disability Health Lab, Leo Cuello for the Center for Children and Families at Georgetown, Ariana Abulafia from the Center for Democracy and Technology, and Sarah Coombs from the National Partnership for Women and Families. Thank you again. Tim, take it away.
Thank you. Your expectations sufficiently lowered.
Yes.
We're going to talk about healthcare challenges and opportunities, which means we will depress you for a few minutes and uplift you by the very end, so help us. We've got an esteemed panel here. We're going to jump right into to questions, and I want to start with Leo, reflecting that time moves very slowly and quickly. It's been about a year since the budget reconciliation bill that Congress passed with vast consequences on tax policy and our social safety net and more, where Medicaid was a particular point of focus. Leo, you've been tracking H.R. 1 now more than anyone. Where are we now?
Great question. I know there's a lot of Medicare experts in the room. If the summer of 2026 was the summer that you were going to sort of dig in and wrap your head around Medicaid policy, some bad news for you. Those of us who have been working on this for decades do not understand what's going on. The people at CMS don't understand what is in the regulation that they are releasing 2 weeks from now. So it is a kind of a wild time. Big picture, H.R. 1 made historic cuts to Medicaid. And so a few ways to think about this are, number one, putting a gigantic implementation job on states. So a lot of state bandwidth, and remember, state Medicaid agencies are the ones running the program in every state. They're really, really distracted by implementing this. The coverage loss associated with H.R. 1, you're looking at predicted 10 million people, so a lot of coverage loss. And I think we can get into this. There's a lot of reasons to think 55 to 64-year-olds are going to bear a lot of the brunt of that coverage loss. And then states are going to lose a lot of money. This law cuts $1 trillion out of the Medicaid budget. And that's going to have very serious consequences for your ability at the state level to do programming for seniors and people with disabilities. So at the same time we're absorbing that H.R. 1, we've also got a fraud narrative going on. We've got tax on immigrant coverage. And we've got some additional clouds on the horizon in terms of threats. We've got 4 pretty major regulations that will be coming out in the next weeks. Some of them are rumored to have some very bad things in them. And then we have the risk of another reconciliation package this summer where some more cuts could happen. So in the Medicaid world, a lot of instability, uncertainty would be the summary.
I want to dig in on a couple of those things because like a key feature of the bill is the deployment of like administrative burden to ration healthcare coverage. And that's through multiple mechanisms related to enrollment and eligibility. I can't keep up with it. So remind us what those are, work reporting and redeterminations, how they'll affect different populations to whom they will apply. And then tell us a little bit about like what you're focused on in some of the upcoming policy on those issues.
Sure. So if you were looking at big picture at H.R. 1, something like 21 different provisions hitting Medicaid. 8 of those hit the Medicaid expansion. And that's where you really see them since they were kind of afraid to attempt to repeal it, they're trying to kind of throw a lot of sand in the gears of expansion. So the biggest one by far is the work requirement. The second biggest one that's going to result in 5 to 6 million people losing their health insurance. The second biggest one, about 700,000 people predicted to lose coverage, is making redeterminations be every 6 months, and that's from a year, so doubling the amount of redeterminations. And then the third, probably biggest one is the limiting retroactive coverage, and then there's also some requirements to add cost sharing. So kind of an assortment of things that are all going to degrade coverage. Now, it's important to, I think, always remind everybody in the room, we are talking here about Medicaid expansion. Remember that Medicaid is a big house. You get in through a lot of different doors, a lot of different categories that people are eligible in. Expansion is just one category. So who are we not talking about? Well, we're not talking about people who are 65 plus, because they do not go into Medicaid expansion. And we are not talking about people who are qualifying for Medicaid on the basis of a disability, right? Or on the basis of a functional impairment. Now, there are a whole bunch of people who go into that Medicaid expansion and are not otherwise getting into Medicaid through one of the other doors. So they might have a disabling condition, they might have a functional impairment, but they're in Medicaid expansion, and these policies will apply to them, right? So a lot of risk there. Right now, the work requirement is really where everyone is very focused, because it's the biggest impact, but it's also the biggest absolute nightmare of an implementation job for the states.
You talked about over 65, you talked about basic eligibility. There are other exceptions that are written into the law, medical frailty or something. And there's an exception for areas, if I'm not mistaken, with high unemployment rates. What do we know so far about how those exceptions are going to be implemented? And what do you think?
Okay, right. So we're talking now specifically about the work requirement, and you sort of get past the work requirement one of two ways. You can comply with the work requirement, 80 hours a month of work, or a work program, or community service, or half-time education, or 80 hours of any of those in combination, or $580 a month of income gets you automatically deemed. So any of those, you're compliant. Now, you can also get around it by getting an exception. The good news is there's a long list of exceptions. One of those exceptions in particular is what is termed medical frailty, and that within it includes disability, substance use disorder, disabling mental health condition, ADL needs, activities of daily living needs, and somebody who has a serious or complex medical condition. So that's a very broad definition that would include a lot of people if interpreted correctly. We have been told that there is a regulation that CMS is required to issue by June 1st that is going to detail everything about these work requirements. So it's expected any day now, probably, just guessing, 2 weeks from now, something like that. What we have heard is that the White House has pushed very hard to tighten those definitions a lot. And so two things they're tightening. The first is that medical frailty definition, turning it into more of a workability definition. So it's not just that you have the chronic condition, but that you show that you can't work. Very, very problematic. And second is the other critical factor is how you show you have that condition, right? And what the law actually says is states do not have to verify the details around people who are requesting one of these exceptions. So for example, if you raised your hand and self-attested to activity of daily living needs under the law, you should be able to get that exception. However, we are told that CMS is going to be pushing quite aggressively to restrict that, require people to have documentation, et cetera. So they narrow the standard and they create a much harder process, and now a lot of people are at risk of not being able to qualify for that exception. The other exception you mentioned, so that exception for medical frailty is one of the mandatory exceptions. Every state has to offer it. There are a suite of 4 exceptions that are optional that states can choose whether or not to implement. Right now, the good news is most states seem to be towards headed towards implementing. There's a KFF CCF survey that sort of can tell you what states have done so far. That survey's available on our website, on the KFF website as well. Those exceptions include one for somebody who has had recent medical attention, so it's like somebody who's in the hospital during the month of application. It includes one for an area that has high unemployment rate, and there's sort of a numerical figure, but also a relative figure. So if your state, even if unemployment isn't that high, but your state is way up, or your region of the state is way up, you could get an exception. And there's one for emergency declarations. So if there is an emergency declaration because of a storm or flood or hurricane, stuff like that, those are all optional.
The literature tells us that administrative barriers tend to disenfranchise those with the greatest needs. There's a lot of reason to be worried here. But I want to pivot. I want to pivot to something else. And at the risk of being booed like a commencement speaker, let's talk about artificial intelligence. Ariana, you look at how technologies impact people with disabilities, and technology is playing a bigger and bigger role in the healthcare space right now with automated decision systems and algorithms affecting benefit coverage decisions. As I prefaced for Leo, where are we? And set the stage for us on the state of play in AI in healthcare, especially for people with disabilities. And then what should a group of advocates be thinking about when we learn about these things?
Sure, yeah. Thank you for the question, Tim. I don't think you gave yourself enough like comedic timing for people to laugh at your joke. It was a good joke.
Thank you. Thank you.
Yeah, so the question of where are we, I would say there's a few sort of like top line trends that you can think about when you're thinking about the integration and the expansion of AI in general, and then sort of kind of like winnowing down more specifically into how it's going to impact healthcare, Medicare, Medicaid. So sort of like first on the general side of things is and this is something everyone in the room probably knows, is that we're seeing AI being incorporated and integrated into more and more systems more and more often, right? Something I say a lot is that we are far past the point where if a person with a disability said, I do not want to use AI, right? Like if I don't want to use, let's say, a large language model, I choose not to use ChatGPT, that doesn't mean that you're not going to interact with AI systems, because they are being incorporated into pretty much every aspect of our lives, including healthcare. And then, so like that's sort of like one top line trend, right? Is that we are seeing these tools being incorporated more and more across systems, and they are impacting people across disabilities also. This is not the sort of thing that is only impacting, let's say, folks who are blind or low vision or deaf or hard of hearing. It's going to impact pretty much everyone across disabilities and across systems. I think that's sort of like the first thing. The second thing that I will say that also could have me booed like a commencement speaker is that I don't see that trend changing anytime soon. I don't think that, particularly in systems like where there is some element of dissatisfaction, right? Whether you're talking about the ways in which healthcare services impact people with disabilities, multiply marginalized people with disabilities. Something I say a lot as a disabled person myself is that I never leave a doctor's appointment or a phone call with an insurance company and say, that was the best time I've ever had, ever, right? Like, you never have that experience, right? And so when you're thinking about healthcare as something that is suboptimal, right, and that may be particularly suboptimal for people with disabilities or multiply marginalized people who are facing, let's say, various sort of levers of oppression that are incorporated into the system, those sorts of systems are actually like really ripe for AI tools, because there's this idea that like AI can make it better. And unfortunately, what we tend to see more often is that when these tools are not incorporated in a way that is thoughtful and in ways that are really centering of affected populations, that they serve as a force multiplier, meaning that they can actually make things worse instead of better. And so the idea of a lot of my work is to think about how, when, and where these tools are incorporated, and how to ensure that we can maximize the benefits while also sort of mitigating any of the harms of that incorporation. So that's kind of like the top line trends, I would say.
Okay. Sarah, make this this is not theoretical, right? Like some of these tools are being deployed in real life government programs right now. Tell us about those and what you see.
Sure, yeah. So you can think about my colleague Kevin DeLebon, who runs an organization called Tectonic Justice, several years ago at this point, filed a lawsuit on HCBS and benefits determinations that were being determined using an algorithmic system. And I'll also take a step back here and say that when we're talking about quote unquote AI, artificial intelligence, one of the things that matters is to set the stage for what do we mean when we are talking about that, right? And so are we talking about an algorithmic system that's being used in that context to determine who gets HCBS benefits, right? Are we talking about a large language model, a chatbot, that is being used for customer service at SSA, as an example, right? And the answer to a certain extent is that we're talking about all of those things, but how we talk about it and the recommendations for implementation and for deployment and for auditing might be slightly different because these are different use cases. But yes, we have seen it used at the state level for benefits determinations. I believe we'll see much more in the way of customer service chatbots pretty much across government services and also private services. Just in general, I think we're going to see more and more chatbots. Some of y'all have probably interacted with AI chatbots, or you've interacted with a customer service chatbot that you feel like might be AI, and it very well might be. So those are also, again, sort of like some top-line trends. But I think I see, again, a future where there is more and more AI being incorporated into decision-making, into coverage determinations, into appeals, that sort of thing.
So, for Sarah now, put it in the CMS context, right? Like it's like happening now. We heard about the Wiser model earlier.
Yeah, sorry, I was not here for that. But I can share, maybe take a step back and just say a little bit about CMMI for those who may not be familiar. So CMMI, Center for Medicare and Medicaid Innovation, has a mandate to test payment and care delivery models that reduce spending while preserving or improving quality of care. And if models are able to meet those really strict statutory requirements, they have the potential to expand in scope and in services. And so with Wiser, I guess I'll share that Wiser is is a new pilot program that started in January. It runs for 6 years in 6 states. Cannot name all of them: Arizona, Ohio, Texas, Washington State. I'm like missing a few others. And it specifically allows CMS to test AI-led prior authorization requests for certain procedures that are deemed by the administration low value or vulnerable to fraud, waste, and abuse. And some of those conditions, it's like because I don't have them at the top of my head, include epidural steroid injections for pain management, skin and tissue substitutes, less invasive treatments for spinal stenosis, nerve stimulation for issues like sleep apnea, incontinence, and others. And so what is interesting about this model is that, of course, this is like the first time that CMMI is testing prior authorization with traditional Medicare beneficiaries. And how it works is that healthcare providers that are treating those certain conditions will have to submit prior authorization requests to CMS contractors. Those CMS contractors then review the service and either deny it or approve it. And then the clinician will have to review the denial decision. And patients, there are some beneficiary protections. So I guess one of them is that there is a limit to how long, a time limit for prior authorization decision. And what we've already seen in some states like Washington State, patients are experiencing 2 to 4 times longer delays in prior authorization decisions for care that you never had to experience prior auth before. Of course, we know that's increasing administrative burden on providers, and so that's increased scrutiny by lawmakers, by advocates, by physicians and clinicians, because we know that there's a risk at delaying and denying care for people that need it. And so I would say that for Wiser, it's one of those models where we have to think, why are we using AI-led programs to review prior auths in traditional Medicare? I think that's a big question because it has the potential to expand to include other services and potentially other states. So that's just one of the models that CMMI, I can give you a concrete example where CMMI is testing those.
Thank you. Okay, back to Ariana. There is federally very little regulatory structure in place for AI systems, and very often technology outstrips the pace with which we make new regulations and guardrails and policies. What should a room full of advocates be thinking about in terms of like the government role to place guardrails on some of these products?
Sure, so I will answer that, but I want to sort of jump off of this really good example, this really good concrete example, just to say as a sort of like a level setting, that one of the concerns with using AI in this sort of context is that there's this idea that AI and algorithmic systems are like these quote unquote black boxes, right? That they come out with these decisions and it's hard to tell, but they come out with decisions based on training data, right? These tools put out a response based on the training data that is input into them, right? And so when we have training data that is under-inclusive of, let's say, particular conditions or particular types of disabilities, you're going to get outputs that are under-inclusive as well. And so I'm not saying for sure that's the case of what's going on, but we have seen sort of in general a under-inclusive data, and I've written a paper on this with some folks at Johns Hopkins who focus specifically on disability data and all of the myriad of reasons why disability data is underrepresented in a lot of these data sets, right? And so that's just kind of as a level setting, if you're an advocate and you're thinking about, okay, why should I maybe be skeptical about the incorporation of AI into this sort of arena? That's one reason why, just in thinking about like fundamentally how do these tools work? And then sort of secondarily, these tools are based on pattern recognition, and when you are feeding them into something that is maybe not like the typical pattern, right? Like someone with a rare disease or a whole bunch of co-disabilities or that sort of thing, they also may not be the best tool to come up with the best outcome. So again, that's sort of like the level setting here. And thinking about if you're an advocate and what can you advocate for. One of the big things I believe is transparency, so that people know when they are interacting with an AI tool, sort of in the beginning of things, not later, not after they have a denial. And I do believe that that is something that should be legally required if it is not already, and if it's not already is a legal question that I'll leave because it's highly dependent. But transparency is a big one. Another one that I specifically make this as a policy recommendation all the time is auditing for disability bias specifically, so that these tools that are being incorporated, especially in these systems that disproportionately serve people with disabilities, that they be audited for bias towards people with disabilities, and both pre-deployment, so before the system is incorporated, but also afterwards, what I call post-deployment. And the reason for that, I give this analogy a lot, is you would never hire someone and then never do a performance review and say like, okay, you got it, good job, right? You would hire someone and then you'd see how they're doing. And if they weren't doing well, you'd do something about it, right? We can do that with AI tools. It's not like once you incorporate it into a system, well, it's too far gone. We have to let it deny people their health care from now until the end of time, right? We can do these pre-audits, but also post, because sometimes it's hard to tell how they're going to work until they're in a system.
We're in a room where skepticism predominates, I think is fair to say, knowing many of you. Ariana, can you give us just but there has to be some potential here to actually deploy some of these tools in ways that improve equity and access, right?
I mean, I think I'll use the chatbots as an example, right? I don't think it's ever necessarily about the tool itself, right? Something that I say a lot is that AI is not good, it is not bad, but it's also never neutral, right? And what I mean by that is that the tools themselves, they're just tools. They're not good, they're not bad, but their incorporation into systems is also never neutral. And so we need to think about what that looks like and who it's impacting. And the chatbots are a good example, right? So a chatbot, in theory, is something that could, let's say, help someone who needs customer service and who has a hard time waiting for a long time on the phone, right? However, those chatbots are not going to be useful unless, again, they are trained on data that is inclusive of people with disabilities. It hallucinates as little as possible, which it can never be zero. It's an inherent limitation of LLMs that they hallucinate. That there are privacy things taking place, right? So that when you're feeding this chatbot maybe sensitive information, that you know that it's not going to be used as part of a training data set for OpenAI or sold to a data broker, right? It would need to be trained on multilingual AI so that people who do not have English as their first language can also interact with it, right? So it's not to say that there is no potential, but it is to say that deployment really matters. And I'm skeptical at this point in time that with all of the focus on winning the AI race that we've kind of made up, that there's a race to incorporate this into all of our social services in particular, that we are not focusing on how to do it well, and it's too important to not do well.
Sarah Coombs, let's take it back to payment model innovation, incorporating AI or not incorporating AI. What has worked well? What should we be optimistic about? What should we be pessimistic about on the CMS-driven payment model side?
Yeah, so as I said, CMS can expand models, right? And so or CMI, and very, very few, a handful of models have actually met the expansion criteria. And so not very many models have really succeeded well, but and there have been mixed results. However, I think I would say that CMMI has proven that care coordination can really improve patient experience, patient outcomes, and some degree lower total cost of care. And so I think I remain optimistic because I think in the fee-for-service system that traditional Medicare is really reliant on, it really does limit the flexibility that providers and clinicians need to provide patients the kind of care that they need that's personalized, that includes interdisciplinary care teams, that addresses social drivers of health and whole person care, that I just think is just too often too limited in fee-for-service and that has misaligned incentives. But there are some missteps, right? And I think one of them, speaking just on the theme of technology, one model that I'm just really wary and cautious of is the access model. I don't know if you all are familiar with. I don't know the acronym. I have it in here. It's Advancing Chronic Care with Effective Scalable Solutions model. And it's a model that reimburses tech care-enabled companies that have patients that use their products and services to better manage some of their chronic conditions like diabetes, hypertension, obesity, cardiovascular disease, chronic kidney disease. And so with that, it's voluntary, and there are two ways that patients can enter the model. The first is that primary care physicians can refer patients to these tech-supported enabled healthcare companies, or that patients can self-select without a referral. And so that makes me think, which Medicare beneficiaries are going to be aware of this model? How are they going to select themselves into this model? Who does that leave behind? And we know that these companies traditionally right now are contracting with employer and commercial plan populations that look very different compared to Medicare beneficiaries that are older, that have more complex care conditions, that may have lower health literacy. And so what comes to mind for me is like when we're building models, when we're designing models, it really needs to have equity at the center. And you know, this model hasn't launched yet. It launches in July and it will run for 10 years. And so there's left to be determined, a lot to be determined. But I think when you think about care, integrating technology into care and payment delivery models, we have to think about health literacy, internet access, access to technologies, people with limited English proficiency, and how might these kinds of models exacerbate disparities. And I can only imagine that this model will work for a subset of Medicare beneficiaries and will leave many others behind. But there are some promising ones, and I do want to be optimistic. And that is the GUIDE model, which many of you may know more than I do. And unlike many of CMI models that are testing how to reduce total cost of care, this particular model is really has the goal to improve the quality of life for people with dementia, reduce the strain for people for caregivers that are caring for their family members, and to really enable people with dementia to live at home as long as possible. And so it provides some respite care and support for caregivers. It provides 24/7 helpline, a navigator, a patient navigator, the things that people really need to comprehensively take care of people with dementia. And of course, we're a women's health organization, and caregivers are disproportionately women. They are often unpaid, and so I think it's a bright spot. We'll see how this model goes, and if any of you are more intimately familiar with the model, I'd love to chat to hear how it's going.
At the risk of breaking the bright spot momentum here, Leo, let's go back to HR1 for just 1 second. There was a pervasive talking point in the development of the reconciliation bill that it wouldn't affect Medicare. How true or false is that, Leo?
So it's false in a lot of ways. The first thing that's really important to understand, I think people in this room probably understand it more than most of the people out there, is that these two programs overlap, right? So about a fifth of Medicare enrollees are reliant on Medicaid. Their health care would not work without Medicaid because Medicaid is covering their costs, their premiums, their cost sharing. And Medicaid is also providing a set of services that Medicare does not provide and are essential. We all know about the HCBS services, but there's also transportation services, right? There are other services that Medicaid is providing. So when you cut Medicaid, you really, really hurt a huge population of people on Medicare, and in some cases, the people who have the most challenges already facing them on Medicare. So specifically, you have the provisions that cut funding, which put a lot of pressure on the Medicaid services targeting seniors and people with disabilities. But then you had direct things, right? Repealing regulations or putting moratoria on regulations that were simplifying the enrollment process and using data to increase enrollment in Medicare savings programs, which are Medicaid programs that reduce Medicare costs, right, which have been under-enrolled. I'm embarrassed to say how long you and I have been talking about under-enrollment in those programs. So you're pulling back regulations that we're going to start to address that. We have a long-term historic problem that the eligibility rules for the non-MAGI population, seniors and people with disabilities, are more complicated than the rules for the MAGI populations, kids, pregnant people, families. What this rule was going to do was align those rules by making the non-MAGI rules better, right? Several things that would improve the enrollment and eligibility process for older adults and people with disabilities, right? that has been held back. Some of those changes will be made permanent over the coming year. And you also had provisions, pull back on provisions dealing with nursing home staffing, and you had pullback on provisions dealing with Medicaid home equity rules, which are basically rules that allow people to have some assets and still remain eligible, and they are freezing those asset limits, which over time, through inflation, will become more and more unreasonable for families and perpetuate intergenerational wealth problems that Medicaid populations have, populations that are disproportionately people of color.
And in addition to directly ending Medicare eligibility for certain classes of immigrants too, so, and of course the nursing facility staffing thing won't, not specifically to Medicare, but will affect a lot of Medicare beneficiaries in ways that all of the estimates would result in increased mortality among a population. So I think, Leo, to sum it up, you're saying it's true that there are no impacts on Medicare as long as we ignore the things that increase costs for Medicare beneficiaries, increase their administrative burden, kick them off of the program, or kill them. Is that fair?
That's
okay.
Pretty fair.
All right, good. You alluded to it earlier, but how concerned should we be about further Medicaid cuts?
So I think you have to think about this in two ways. The first is immediate threats through another reconciliation package. Right now, so what's happening right now is there's a reconciliation package moving around, right, immigrant border stuff that so far doesn't have a lot of toxic stuff in it. But there's conversation about another reconciliation package after that one goes through. It doesn't seem to have a critical mass yet, so hopefully it never turns into something. But I think people should be prepared to talk to the American public about what this means for their coverage. However, so that's kind of a new problem, but we've got an existing underlying problem, which is a historic cut to Medicaid financing. And so what that means is your state is going to lose Medicaid money that it thought it had. And it's also going to lose the ability to raise new money that it thought it could raise if things went wrong at any point. And what that means in the context of Medicaid, where you have a state that has a balanced budget, is the state has to address that problem somehow. And we have a big problem, which is that a lot of the services that seniors and people with disabilities rely upon are optional services that are quite expensive. So when states are looking to make cuts, they're looking at, okay, where can we make cuts that we can pull back some money? And certainly home and community-based service programs are a type of target. And the other thing we should say is that when they're not targeting eligibility or services, those are actually the second and third things they get to. The first thing they get to is provider rates. And anybody who works with seniors who try to get home attendant care knows that you can get hours prescribed. That doesn't mean you can actually fill the hours because we have a shortage of home health care workers. Well, if you take the very low payment rates that currently exist and you make them even lower, right, that makes it even harder to get those home health aides. And you layer onto that the fact that home health aid work is disproportionately done by immigrants. And so when you attack immigrants, you also hurt that workforce, right? So huge impacts.
You're pivoting into, I want to hit two other issues, and then we're gonna get optimistic. But you touched on immigration, so I want to see if the other panels have any other comments on just the interplay of immigration policy and health policy at this moment in time in 2026.
I mean, I'll just add that, again, as a women's health organization, we look at immigrant justice as reproductive justice, and I know that I'm talking to a room full of Medicare advocates, but I think it's just important to view it as inextricably linked, and I think, we just fundamentally believe that everyone, regardless of their status, should have access to health care, bodily autonomy, and the right to give birth and raise children in safe and sustainable communities. And so while we're not a leading, immigrant justice organization, we absolutely support our partners in this work because we know that, the health system cannot work if everyone doesn't have access to care.
For anyone who wants it here on the panel, the federal government has made a big focus on fraud, especially in the Medicaid program. I suspect that I speak for everyone in this room by saying fraud is bad. With that said, how should we be thinking right now about the pervasive focus on fraud, waste, and abuse?
So fraud was the dominant talking point, or one of the dominant talking points in the HR1 effort, and the historic $1 trillion cuts in HR1 are, by our calculations, 2.5% about fraud. So that should tell you already where the narrative is compared to where the things that are happening are, right? The 10 million people that lose coverage under HR1 has nothing to do with fraud. What we're seeing right now is a pretty historic attack on state Medicaid programs, with the federal government basically saying to them, we are going to defer payment to you, withhold payment to you, meaning we are going to not give you Medicaid match for some things that you have already paid for, and we are going to withhold future Medicaid payments until we get what we want. That is very different than the manner in which fraud has been dealt with in Medicaid over time, which is the states and the federal government collaborating through state Medicaid fraud units where every dollar you invest in them saves $3 of losses. In fact, what we see is the federal government threatening to punish some of the state Medicaid fraud units. So we have a wildly different environment than we normally have. And the really important thing that this audience needs to understand is the epicenter for the fraud allegation is home-based care, home and community care. Of 1.3 billion withheld or deferred announced for California, 1.1 is home care. Why is that happening? It's happening because these are non-traditional providers. It's happening because sometimes people run their own budget. It's happening because sometimes people are employing family members. And the people who are making these decisions do not understand what home and community-based care is and what it means for seniors and for people with disabilities. And we all have to do a really bang-up job about telling that story so people can understand what these services are. And part of the reason this is important is one of the things that this administration is saying is its reason for being suspicious about these home-based services is that usage of these services is growing. That's literally what we've all been trying to do the last 20 years, right? That is what we want. What everybody wants is more of these home-based services because they are where people want to be treated and they save money because we reduce institutional care, right? So literally their justification is itself wildly misunderstanding what is happening. So I think this fraud narrative is going to be their meta umbrella for a lot of the different specific things that happen. And we have to tell the story of who are these people that are going to be hurt by this fraud attack. And there are, guess what, a lot of Americans who are going to be very surprised and upset when they find out that, mom's home attendant was actually being paid for by Medicaid, and that's what they just cut, right?
Right.
They don't understand that right now. We have to tell that story.
Everyone gets 1 minute. Tell us something we should be focusing on thematically or programmatically and inspire us to feel good and excited and motivated. Sarah Kuhn.
Well, I think Wendell said it in the last panel. I think something as simple advocacy is just educating our lawmakers. There's a lot that they do not know. And just kind of going back to the WISER model just for a second, I think that's an example where advocating on the Hill, sharing stories about what is happening to people on the ground because of that model really has led, just that growing criticism has really forced CMS to actually indefinitely delay or just cut back some of the services that they intended to include in those procedures that were intended to be in the model in the first place. And now the GAO also just ruled that the WISER model they concluded that the WISER model is a rule under the CRA. So that could potentially lead to Congress completely, limiting funding for the WISER model altogether. And so that's just one example where I think it's bipartisan. Both Democrats and Republicans have been scrutinizing that model. And so I just think it's one of the ways that we can share stories, collect stories, share stories, educate lawmakers. Maybe that's not the most visionary example, but it's one to say that I think we got to just continue to grind and do the work.
Ariane.
Sure, yeah. So on the tech stuff, I think what I'll say is that there's a tendency when advocates sort of start interacting with or trying to understand the role in which AI tools are playing in whatever their specific area of expertise is, to sort of back off and to say that feels like the tech stuff feels like its own separate thing that you need to be a coder or a technologist or computer scientist to really understand. And the thing that I will say is that that is not the case. I get asked this question when I talk to students a lot of what will set me apart as, by the time I graduate, everyone's going to know how to use an LLM. So what's going to set me apart? I think the thing that sets apart someone when it comes to AI, when it comes to being a good advocate in a system where AI is being incorporated, is actually not understanding so much the tool itself, but understanding very deeply the system, right? And so people with disabilities, advocates for Medicaid, for Medicare, for all of the things that have led to really big strides in the disability rights movement over time, we actually know how to address disability discrimination. We know how to expand social services and programs and make it so that we live in a better world, right? Because I'm a kid of the ADA generation, and I'm very grateful to the people who fought for that law that got me to where I am right now, right? And so we actually already as a community really know how to do this. The AI tools don't make things inherently different. We can use the same strategies, the same organizing, the same principles to move forward. And then you just tap in people as you need them to know a little bit about the tool and how it works. But fundamentally, we're not talking about anything different here. It just looks a little bit different.
Leo.
So just like I said that I think we can use this moment to really teach the nation what home and community-based services are. We've got a work requirement that's going to launch on January 1st, and that work requirement is premised on a lot of faulty stereotypes about Medicaid and who is using Medicaid and why, right? And the stereotype they would like to put out there is 22-year-old gamer sitting on his parents' couch, right? That's what they're trying to put out as the stereotype, right? Which is called what it is. And who is using Medicaid? It's working families who cannot get a work insurance, right? Because low-income employers do not offer health insurance. That's what the KFF data will show you if you look at it, right? That's what the facts are if you will look at them. Who is a population that really, really depends on this Medicaid coverage? 55 to 64-year-olds who are dealing with the onset of chronic conditions that are impacting their employability, impacting their function, right? And in many cases, they can continue to work and they can continue to function if we get them the care they need, right? So I look at this as an opportunity to you want to have a conversation about fraud in HCBS? I'm going to tell you the stories about the people who are benefited. You want to have a conversation about work requirements? We're going to tell you who is actually in the Medicaid population, right? And I think it's our opportunity to really win that part of the narrative, which will make it much harder for them to do damage to the program long term.
Pretty good. All right, I'm answering my own question. Leo mentioned a particular provision in H.R. 1 that put a moratorium on federal enforcement of some rules that would help more people get into something called the Medicare savings programs. I just want to expand on this for 1 second. Look, Medicare is only affordable for low-income people because of the Medicare savings programs. Again, they're Medicaid eligibility categories, and they cover your Part A and B premiums and cost sharing. So by making those subsidies harder to access HR 1 makes Medicare coverage more expensive for more people, like, full stop. But we should recognize, too, that for far longer, as Leo also alluded to, we have been disenfranchising people through red tape for decades, right? Like, enrolling in these subsidies is confusing, and for many people, it's like an adversarial process. As a result, like, by all estimates, no more than 60% of the eligible people are actually enrolled in these things, which means we literally have millions of Americans living at or near the poverty level, $12,000 a year, and they have $2,400 of Part B premiums taken out of their Social Security checks, like, every year, and they're exposed to really significant cost-sharing levels because they can't afford a Medigap product. So these realities, they're like small and crass, but like these realities are a big reason why over a third of Medicare beneficiaries report delaying or going without a needed service because of cost-related barriers. And those financial barriers and medical debt burden are especially prevalent among Medicare beneficiaries under the age of 65. So it's like a pervasive cost-related problem in a program that we really, really care about. And so if we care about reducing poverty and improving access to Medicare, like, we do need to make sure that we can get people into the subsidy programs that already exist for them. HR 1 stops some of that action on the federal level. It does not stop it at the state level. And so I want to go back to that theme of, like, there is action and possibility and optimism at the state level. And it is not a partisan issue. There are states from Louisiana to Oregon to Maine that have taken significant steps to liberalize enrollment into these subsidy programs. And there's a lot of good reasons for them to do it, including some very small ones related to the current challenges, related to reducing their own administrative burden to administer these programs, reducing their own error rates, we didn't even talk about this, that will subject them to future financial penalties. Louisiana and Mississippi eliminated the asset tests for the Medicare savings programs. Maine and New York have significantly expanded and eliminated kind of the Medicare cliff that people fall off when they turn 65. So these are like really, like, these are possible things even in today's environment. And I hope many of you will join me in trying to shine some more light and make forward progress on that. But first, I hope you will join me in a round of applause for our wonderful panel. And now we're going to welcome to the stage Melanie Lambert from the Center for Medicare Advocacy. Melanie.
Hi, good afternoon, everyone. I'm honored to be here with all of you today and so pleased to be attending my second summit as one of the newer members of the Center's team. It's truly inspiring to be a part of a community of professionals so deeply committed to protecting and strengthening Medicare, not just as a healthcare program, but as a promise to older adults, people with disabilities, and future generations who have worked and paid into a system that is meant to pay them back by providing the care that they need and deserve. Up next, we're sharing a community voice. This is a moment to hear directly from someone that CMA helped to win coverage for necessary care. In the following video, we will hear from Kara Bonnell, a Medicare beneficiary from Michigan who has had to fight numerous battles to get and keep the care that she needs and deserves, and Weiwei Kwok, senior attorney at the center who has assisted Kara with fighting for necessary care, including her recent battle to obtain coverage for an air fluidized mattress and a rolling shower chair to maintain her health and independence. Kara Bonnell initially contacted the center several years ago for help when her home health aid services had been terminated by her home health agency, despite no change in her condition or a physician-ordered care plan, sending her scrambling to patch together private pay aid services to avoid institutionalization. Inadequate and inconsistent home care contributed to the serious health complications, protracted hospital stays, and multiple surgeries she experienced in recent years. Everyone here today knows that situations like Kara's are unfortunately not uncommon, but Kara continues to fight for the care she deserves and has allowed us to share her story as In Weiwei's words, Kara just wants to make the system better for others. I am so grateful to be a part of the Center's incredible team of advocates and of this broader community of partners and allies who fight alongside people like Kara to ensure that dignity, access, and justice remain at the heart of our healthcare system. And I'm so proud to introduce this year's Community Voice, a segment that reminds us who we are here for and of the promise we're fighting to fulfill. Thanks.
Hello, Kara. How are you this morning? Good. Okay. Thank you so much for doing this interview with us.
You're welcome.
Please, could you tell us a little bit about yourself?
Well, I am going to be 56 this year. I was diagnosed with multiple sclerosis when I was 17, so I've had MS for 38 years. I went to school, got my education, and I got a bachelor's in education. I taught school for 18 years. I taught middle school, which is 5th through 8th grade. I taught them math and English, and I taught walking, and I taught from a scooter, and then I also taught from a wheelchair. I did go out on Social Security disability at that point because I needed a scribe to actually write things on the board and do different things for myself. And at that point, I was getting worse, so I went out on Social Security disability. I do have 2 kids, and that's, and well, I guess I should say, I've gotten quite a bit worse with my multiple sclerosis. I am technically a quadriplegic. I can feel, but I can't use my arms and or my legs.
Kara, how long have you been enrolled in Medicare?
When I went out on disability in 2012, that's when I started the Social Security disability and the Medicare. At that point in time, too, I took retirement disability, which gave me the Medicare Advantage plan with Blue Cross.
And could you tell us what medical issues or problems with Medicare you were having that led you to contact the Center for Medicare Advocacy?
Well, Medicare doesn't like to approve many items. They make it very difficult. As far as with the shower chair, I needed it because you couldn't necessarily get a lift into my bathroom and put me on a shower chair per se, like a bench. I needed the rolling shower chair, and it needed to be brought out to a bed, and I needed to be put in at that point. I cannot sit straight up, so I needed to be reclined, and I needed it so that my legs would be locked in or they would fall off. And Medicare did not see that was necessary. And, well, at that point, though, I did contact the Medicare Advocacy, and they helped me come up with ideas and ways to start doing the process. The first time the prescription was put in for the shower chair, I was denied. I appealed. It was denied. We went to the ALJ judge, and it was still denied. So at that point in time, we got a different prescription. The Medicare Advocacy helped me come up with different coding to put down with it, and then they denied it again. They looked at it as a shower sponge, for a tub, and that is not exactly what it was. We appealed, and at that point in time, with the help of Medicare advocacy, they realized it was more of a mobility device, that it was necessary for my care because I had received wounds from surgery, and you have to keep them washed and cleaned, and a bed bath is not adequate. You need a shower.
How did it make you feel when you were being denied for something so important to you, this rolling shower chair?
Well, when they consider it personal hygiene is necessary. Otherwise, you're going to get more infections, more issues, and more sickness. And I feel like insurance, even Medicare, doesn't look at the full point of everything. They just want to deny. And if it wasn't for contacting Medicare advocacy and going through the whole process, I still think it would be denied, even in reference to the bed I currently have. They fought me on that with a wound.
Have you had experiences with Medicare appeals that you found were difficult?
One of the ones I tried was for a sit-to-stand lift, and they kept denying it. And then, of course, I got it, but not through Medicare. I think they deny many things that are necessary and should be approved.
I agree with you there.
Mm-hmm.
Was it helpful to you to have someone attend your hearing with you?
Yes, it was, because with the sit-to-stand lift, it was all me. And when, like even with the ALJ judge, when I was working on that, and of course it got denied, I had just me, and then I had on the other end a Blue Cross person, a Medicare person, and another doctor, and I felt like it was 3 against 1. And they pushed their point. I pushed mine, but I didn't have all the necessary documentation that the Medicare advocacy group came up with for me. And through the Medicare advocacy group, too, they were able to help gather up all the necessary doctor's letters and prescriptions and everything necessary that actually got the shower chair approved.
I want to thank Melanie and Weiwei, and particularly Ms. Bunnell for sharing her story with us. And I feel like I'm about to say exactly the same thing that I said last year when we highlighted one of the stories of someone we were able to help. This should not happen. This should be rare, if ever it should occur. But unfortunately, it is not. We are in a healthcare system where it takes a team of advocates and attorneys to find exactly the right way to code an item or medical equipment, the right citation to make to try to convince someone who's making a decision about Medicare coverage that this is something that this person needs. It is warranted. We should not be in a system that puts up barrier after barrier to someone who needs basic services and amenities. Rather, we should have a system that goes out of its way to try to accommodate people and get them what they need. We are a long way from that. We will continue to try to fight for it. I know all of you will continue to help us and work in your own ways to try to find that better system. We're going to take another 30-minute break, both here in the room and online. We'll see you again shortly. Thank you.
back. Here we are.
Before we start this next panel, I wanted to take a quick moment to thank some of our sponsors, including the Medicare Rights Center and Jonathan Kirkendall.
Thank you.
Similar to how Icarus flew too close to the sun out of an abundance of hubris, somehow I thought it would be a good idea to schedule a 30-minute panel to talk about the challenges of long-term care and how we fix them. So buckle up. Hopefully this will be of some use to somebody at some point in time. I am thrilled to moderate this panel of 3 experts who could really speak on this topic for hours, but they are being greatly truncated in what we're asking them to do. We will try to be succinct. So I have with me Allison Barkoff, professor at Milken School of Public Health at George Washington University, a senior fellow at NASI, and immediate past administrator, really led the administration for community living.
Yep.
We have Natalie Keene from Justice in Aging, the managing director of Health Advocacy, who leads their legislative administrative health advocacy here in DC. And we have our very own Toby Edelman, who has been, that was an emphasis, who's been representing older people in long-term care facilities since 1977. Thank you all for being here. Earlier today, we heard about some of the challenges facing our healthcare system and how some of these challenges have become more pronounced. Now we want to spend a little bit of time talking about perhaps one of the biggest, most intractable, longest-running challenges, and that is access to meaningful, accessible, and affordable long-term care coverage, which spans access to care in the home, assisted living, and nursing facilities. So given our limited time, we're going to try to stick to the broad themes, but at the same time, long-term care is becoming more challenging, as we heard a little bit in the panel prior, so we will also touch on that. So let's make sure we're all on the same page. Let's just start with the basics. When we say long-term care or LTSS, what are we talking about? What does that mean, Allison, for people with disabilities?
So first of all, I am thrilled to be at a Medicare conference talking about LTSS. And we are going to spend as much time talking about maybe the glass half full about why it matters and why y'all might be in the middle of where we might be going long term. So what do we mean by long-term services and supports? Those are the services that help people with activities of daily living, thinking of eating, bathing, bathing, getting dressed, as well as what we call instrumental activities of daily living. So managing your finances, cooking, going out in the community. Those are the things that if we're looking on the community side, it helps people stay in their own homes and communities and participate, and they're critical supports to people in institutional settings. Major funder, Medicaid. The Medicaid has pretty much been the only game in town. Maybe looking forward, not so much so yet. The vast majority of people think Medicare covers it, and when they find out, it is very late for them. Private insurance doesn't cover, and most people cannot private pay. We have shifted over time where most people receive long-term services and supports, with the vast majority of people receiving them in the community and more than 60% of spending. Yet Medicaid, the game in town right now, has an institutional bias, is the word we use, where institutional care is mandatory, home and community-based services are optional, and that's why we have about 700,000 people on waiting lists. The last thing that I'll just say is, from the disability perspective, covers people with all types of disabilities across the lifespan, children to older adults with disabilities, as well as all types of disabilities, from physical disabilities, intellectual disabilities, and psychiatric disabilities. And really key as a civil rights lawyer, this is not just seen as access to health care. This is a civil and human right protected in disability rights laws, and that has been a big impetus, particularly the Supreme Court's Olmstead decision, in helping expand and push access towards home and community-based services, parentheses, when we get to threats, everything I've talked about is at risk. Okay.
Thanks,
How's that 30 seconds on LTSS?
Perfect. Natalie, what would you add to what Allison said about LTSS or long-term care for older adults?
Yeah, so for older adults, as Allison said, Medicaid is the only game in town. A lot of people are surprised when they reach Medicare age that Medicare isn't going to cover everything that they need to be able to stay at home. So Medicaid is covering home and community-based services, things like adult day care, as well as personal care at home. And it's so important because these services are simply unaffordable for most older adults. So thanks to KFF, we know a lot about Medicare beneficiaries and their financial well-being. So about 75% of Medicare beneficiaries are living on $80,000 a year or less of income. So very little disposable income, much less enough to cover the cost of a personal care aide or nursing facility care. Also, for older adults, we know people overwhelmingly want to age in place, and this is true for people with disabilities of all ages. But for older adults, like that is, becoming more and more something people are expressing that they want. But we see a lot of gaps and disparities in who gets to do that. So the Medicaid program spending has been changing over time to spend more money on home-based care compared to care in nursing facilities and other institutions. But for older adults, that rebalancing ratio is slower to come over to the home-based care side. And I think a lot of it is that, when people have maybe a stroke or they have Alzheimer's or dementia and their care needs increase, they don't really have a choice. They can't afford to be on a waiting list. So they end up going into a nursing home. People with Alzheimer's and dementia especially are cared for in nursing homes at extremely high rates compared to their peers at the same age. And we heard earlier about the guide model as something that's maybe helping reverse that trend as well. Also, older women, LGBTQ older adults who are more likely to live alone and don't have family caregivers. Family caregivers still, even with Medicaid, we have to recognize the role of unpaid family caregiving in our long-term care system. So if you don't have a family caregiver, that's also putting you at risk. And the program is, under threat, but we're here to talk about some solutions too. So.
Thanks, Natalie. So, Toby, much of the focus on long-term care in recent years has been on keeping people in their homes, but as Natalie mentioned, an important piece of that are nursing facilities and assisted living. Where do those fit in to the long-term care universe?
All right. Well, most people we know, probably all of us, want to live at home. But there's always going to be a need for some congregate settings for people who don't want to live alone or don't want to live with their families or don't have any families. And for some people, nursing homes can, in fact, be a better alternative. They might like the companionship, the activities, the fact that there's food there 3 times a day and snacks, and that somebody will be cleaning their living space. Home care has some problems for people, especially those who are living alone. They may worry that the caregiver won't be able to get to them in the snowstorm or will have a family crisis and not show up. So nursing homes can be a good place. And as somebody who's worked on trying to make nursing homes better for 49 years, I'd like to think that there are some, and I know there are some that do a good job. But obviously most people want to live at home, and people have voted with their feet. For at least the last 12 years, Medicaid has spent more money on HCBS than on nursing homes, even though nursing homes, as Allison said, are mandatory and HCBS services are optional. I know what home means in HCBS, but what is community-based? Nursing homes are not considered community-based services although of course they're physically located in communities. What community-based services means in HCBS is assisted living. And that's a type of congregate living that really expanded after the 1987 nursing home reform law that I'll talk about a little bit later. The proponents of assisted living took the words they liked from the nursing home reform law: quality of life, residence care, you have control and autonomy, it's a great place. What they didn't take was any of the standards of care, and certainly not the regulatory oversight system. But assisted living residents look a lot like nursing home residents, and increasingly they look like nursing home residents. Yesterday, AARP's Public Policy Institute released a new paper on assisted living, which I'm just starting to read. But what I did see yesterday was that the percentage of people in assisted living who have Alzheimer's or dementia is larger. The percentage of people with those disabilities is larger in assisted living than in nursing homes, 44% compared to 41%. So a lot of these people look like nursing home residents, but there's no federal regulation of assisted living, and residents in these facilities are left to the mercy of state legislators to write meaningful and appropriate standards and to enforce them. Some states do, and many don't. Assisted living, I think, began essentially as a private pay setting, but there were some awkward conversations that came about as a result. Imagine putting your mother in assisted living and saying, what happens when my mother's life savings of $100,000 are used up? Then what happens? Assisted living had to say, she has to leave. This is private pay only. And so they started asking for Medicaid and now got Medicaid money. I checked yesterday, and 18% of assisted living residents are using Medicaid, nearly 1 out of 5. But again, no federal standards, no federal oversight. More than 25 years ago, at one of the first hearings on assisted living, a senator said, gee, maybe we should have some federal regulations. We don't usually just give private businesses public money and say, do whatever you want. We have some strings attached. Well, that issue is obviously more serious today than it was 25 years ago. We have more residents in assisted living, more Medicaid money. The residents in assisted living look like nursing home residents. So from my perspective, it is long past time to enact some federal standards for assisted living.
All right. So in our last panel, Leo did an admirable job of teeing up some of what is going on with respect to care in the home, particularly home and community-based services. So really, Allison, Natalie, what you want to elaborate on any of the challenges that are facing long-term care as it pertains particularly to people in the home?
Okay. I'll start on a few high-level things, and then Natalie can add in more. You know, we already came in, as we were talking about, with many, many people who would prefer to receive services in their own home and community, but because it's optional, almost 700,000 people sitting on waiting lists, a direct care workforce crisis, and a growing number of family caregivers, 45% increase over the last decade because of the lack of access to services. That's where we were before H.R. 1, the reconciliation bill that was passed over the summer. As was talked about in the last panel, you know, all of us sat through those 3 a.m. hearings where we were told, you are being lied to, people with disabilities and older adults. This bill is about protecting Medicaid for the most vulnerable people. There will be no cuts. And we all came in with our research. Every single time states have budget shortfalls, the first thing to go, because it is what can go, is optional services. And sadly, $1 trillion in cuts, which the worst isn't even happening until 2027, is already starting to have impacts in states. I launched, and I'm really excited, I have my whole team of research assistants in the back corner. We were like, we need to be ready to show what is happening and what is happening in real time. And we got a planning grant and thought we had plenty of time because we weren't going to see things until next year. We have already seen 60 actions in 25 states. The vast majority are cuts. Cuts in lots of different ways. Cuts to provider rates, new limits on services, lower waiver slots, higher level of care that we are already seeing. And that is the tip of the iceberg because, as Leo talked about, most of the funding cuts haven't started yet. That's one. Number two, we can talk much more about it. I thought Leo did a great job talking about this sudden pivot from 30 years of bipartisan support of rebalancing towards home and community-based services and promises to protect older adults and people with disabilities as recently as July to suddenly a narrative that HCBS is providing things that families should do, and that is fraud. And that increases, that our intentional successes equals fraud. I'd encourage you to read the letter to California. That is how thin the evidence is. It is pretty existential, I would say right now. And I would just say we are in a really critical point where, to Leo's point, we have got to talk about what these services are, what they mean, and what cuts will mean, and the huge costs it will have to our system. We do not have quality nursing homes for people to go to when we start cutting services. It is, having done 30 years of advocacy, I feel like we are on the shakiest ground that we have been on in a very long time.
I'll just add a specific example also from California about how if the state were to cut its HCBS programs just by a few percentage points in terms of spending, the nursing facilities would fill up. There are not enough beds in nursing facilities to serve everyone, and the state would be spending more money. The federal government would also be spending more money on LTSS. So it's very short-sighted to be cutting home and community-based services, but it is the by and far the largest target because it's what's available for states. I also wanted to talk a little bit more about caregivers and other ways that they're being attacked and threatened from HR 1 in terms of the work requirements. Mm-hmm. So Leo explained those apply to people under age 65, people enrolled in the Medicaid expansion. Well, a lot of family caregivers are in that population as well. And again, thanks to some research that Allison and others did, showed, really the average person who is not working and is subject to these work requirements is a older woman who is likely caregiving for another adult in their household. So having those work requirements directly impacts those caregivers, but that also is going to impact the older adults and people with disabilities who need their care. And yeah, so it's many different attacks coming from different angles. And also, I just wanted to note how, this optional nature of HCBS, it's so, it puts it in a target, and it's been this way for 40 years, right? It's been a demonstration. We've demonstrated that it works, that it's what people want. And so I think we really have to be thinking forward, and I know we're going to get to that, but setting that up.
All right.
Tell me, in the nursing home context, how are things becoming more challenging?
Well, they're devastating. The Medicaid cuts affect nursing homes. 2/3 of residents rely on Medicaid. Medicare is a very limited benefit. A benefit period is 100 days. That's the maximum anybody can get in a benefit period. The average is 20 days, and in Medicare Advantage, even fewer days. So people then become private pay and become poor and become eligible for Medicaid. So cuts in Medicaid are devastating, and the nursing homes are going to cut back to the extent that they can. The immigration issues are really very challenging for nursing home residents as well. About a quarter of the staff are immigrants with various types of legal and non-legal standing. But even people who are here with every single paper they're supposed to have are afraid to go to work because the raids are starting in nursing homes as well. And so it's a devastating time for residents. And the people that I talk to, that I work with, who talk to residents every day, say that the staffing levels have never been lower. It's very bad, and they were always way too low. So it's bad.
So now that we all have an in-depth and comprehensive understanding of long-term care and the challenges that we face
We're
in the
ready.
long-term care system, what can we do to make it better? Where do we go from here? And Toby, let's stay with you because I think you might have some historical observations to make.
Yeah, well, I think some parts of the nursing home reform law establish principles that I would consider universal for all of us. So wherever people live, they retain their rights as citizens. If they're at home or in a congregate setting, they are citizens. They should have their rights protected. They should be able to participate in their health care decisions, meet with whoever they want to meet with. That was a big deal in nursing homes. Whenever they want to meet with them, they shouldn't be given antipsychotic drugs or other inappropriate drugs when they don't have a psychosis. These drugs are not meant for people with dementia. So caregivers should be trained. They should know how to provide care. There also needs to be an oversight system of some type to make sure people are getting what they need. And when public funds are involved, and certainly the long-term care industry would be nothing without Medicare and Medicaid, there needs to be some systems in place to assure that the funds are spent on care and not on excessive private profit for the owners and operators, as we see with private equity, real estate investment trusts, and a whole variety of pretty shady operators. My second point is that I think nursing home advocates have a lot of experience working with residents, talking to them, learning from them about what they want and need, and we have experience in establishing and trying to implement standards of care, trying to implement that 1987 nursing home reform law. We can try to help as new sources of care and new laws are developed. And finally, I know we're in terrible times, and I don't want to be a Pollyanna, but we have had bad times before. Maybe not this bad, but they were bad. But I do want to leave on a positive note. Right after the election in 2024, I prepared a PowerPoint, and then we hosted a webinar on our prior experience with bad times. On day one of the Reagan administration, January 21st, 1981, the first order of business at the Healthcare Financing Administration, the predecessor to CMS, was repealing residents' rights regulations that the Carter administration had proposed and implemented. And it went downhill from there. We had a rumor that residents' rights were going to be removed entirely from the regulations because the nursing home industry said there was no statutory authority to give residents' rights. When the government had to back down on changing the standards of care, they said, okay, we won't do the survey the way we used to. We'll do less than annual survey. We'll have self-survey. We'll have deemed status for the Joint Commission, which at that point used to schedule their surveys, their analyses of whether facilities were in compliance with the requirements. We will have Joint Commission, and those survey results would never be public. We were absolutely alarmed, but we also knew we were outnumbered. And then we knew we had to keep going. We had to do what we needed to do to try to turn things around. By December 1987, we had the Nursing Home Reform Act. It was lengthy and extremely detailed. It goes on for pages and pages. And people who are used to Medicaid laws having a few words, this law, some of the provisions look like regulations because they were regulations. They were detailed, very detailed. That law changed everything about nursing homes, the standards of care. The residents certainly had definite rights specified. It was the first federal law to talk about quality of life, recognizing that nursing homes are homes where people live, not just where they get health care. We had nurse aid training. At the time the law was passed, half the states did not require that nurse aides have any training, could come in off the street and be hired and start working. And we had a survey process to determine whether facilities were meeting standards and an enforcement system, presumably to take action. So that was an extraordinary law. And in retrospect, we realized we had a lot going for us that made that law possible. There were people inside the administration who must have been sending us in plain envelopes those leaked drafts of proposed regs. And so we knew what was going on. There was Robert Pear, an extraordinary, highly respected reporter at the New York Times who covered domestic policy. Nursing homes were one of his multiple issues, but he reported on that issue repeatedly, often on the front page of the paper. We had a very thoughtful and independent report by the Institute of Medicine that described what was wrong and how it should be fixed. We had Kirk Douglas, an actor, who was the honorary chair of the Advocates Campaign for Quality Care. It was a coalition organized by the resident advocacy group, now Consumer Voice, to make the Institute of Medicine report a reality. And when Kirk Douglas came to be our honorary chair, the members of Congress showed up to see him because they just loved him. The nursing home industry participated in our campaign, and the Congress we had was very different from today's Congress. They were informed. It wasn't perfect, but they were informed. They were respectful to each other. They worked together. All members of the Senate Aging Committee, Democrats and Republicans alike, signed letters to President Reagan saying these regulations are terrible. You've got to stop this. We're not going to approve it. Now, we didn't know that we had these things in the 80s. We didn't know we had these positive points. And our challenges seemed very formidable. We had a hostile administration listening only to the nursing home industry. My point is, we know our challenges now. What we don't know is what will work to get us the systems and care that we believe are critical for the people we care about. We don't know who our champions will be, but we need to press forward with our advocacy on behalf of the people we care about. Maybe these difficult times will lead to a dramatically new and better future. And on our planning call, Alison Barkoff had a phrase that I thought was just fabulous. She said, maybe we'll go from the, quote, the politically impossible to the politically inevitable. That's what happened with the nursing home reform law. From complete chaos and everything is being disappeared and we're losing everything we've ever had to the best law we ever had at the federal level. So I think we have to try, and I believe eventually, ultimately, we will prevail and get what we know we need. Thank you.
Toby. All right. So, Natalie, Allison, how we get there?
I deeply in my soul believe we have passed the threshold of long-term services and supports being the politically impossible to the politically inevitable. The growing demographics, the huge movement around caregiving, and the decimation of Medicaid has created this momentum of people to be incredibly bold. And that brings us to here, which is we have to fix Medicaid. We have to get at least home care and nursing home care on level footing. There are bills that just got reintroduced that Natalie and I have both been part of that are picking up steam, but we also need to be thinking outside of Medicaid, a poverty program as our only solution, and the momentum is growing to actually match people's expectation to what is in Medicare, to have some kind of home care benefit. And Natalie can talk more about it, but today we just had, and a number of us have been, this happens because years of work to say, healthcare reform, we need big pillars, and one of them has to be long-term services and supports. And today the Senate Finance Committee put out a Dear Colleague letter with Ranking Member Wyden, with 17 other senators, of course, at the moment all Democratic, but putting a stake in the ground to say, we are going to work with the community, we're going to think outside of just Medicaid, and we are going to come up with the big, bold ideas. So when that window opens, we can move and do what we need to do.
Yeah, I'll just add, I think we know and we're seeing we can't go back to the status quo. That's not the goal. We're not just trying to repeal H.R. 1, we're trying to reimagine and rebuild. And so I'm really excited that Medicare is coming into this conversation in many ways. So thinking about strengthening and enforcing the existing home health care benefit, but also adding home-based care for people on Medicare. Our goal, our North Star is to get to universal coverage so that everyone who needs long-term services and supports can get it when and where they need it.
So that is a perfect place to stop and thank the panel for, again, in-depth treatise on long-term care.
Right.
Thank you for agreeing to participate in the impossible task. Thank you, Allison. Thank you, Natalie. Thank you, Toby.
Thank you.
Now I'd like to bring up our litigation director, Josh Norris.
Good afternoon. How's everybody doing? It's 3:30. So thank you all for being here. This is my first summit. I'm so glad to be here. Josh Norris, I'm the new litigation director here at the center. And I'm going to talk to you a little bit about the role of litigation and legal advocacy in the context of human service systems like Medicare. So first, and this is kind of going back to basics a little here, I want everyone to consider for a moment what keeps them safe and well, beyond simply the activities and habits that you've adopted. So besides eating well, and we've eaten well today, getting enough sleep, staying active, what are the things in your life that keep you safe and well? It's not a hard question, I don't believe, to answer, but I don't think we consider that question enough, particularly in advocating for and with vulnerable people. I'll venture to guess that for most of you, your safety and well-being derive in large measure from the people in your lives. Family, friends, neighbors, coworkers. These are people you are engaged with in some form of reciprocal relationships of care and common interest. They're there when the times are good, and more importantly, when times are bad. They're there when they provide connection, support, assistance, and hopefully some laughter and joy too. They challenge you, inspire you, and actually provide really important safeguards around your thinking and the decisions you make in your life. These reciprocal relationships provide context, meaning, and purpose in our lives through our family life, our community life, and our work life. Also to venture to guess that for most of you, having a home is a big part of your safety and well-being. It gives you a sense of place in the world. It's yours. It will be there when you get home tonight, or when you get back from this trip to DC. Is where you maintain yourself and your family. And you know where you will lay your head down to sleep at night and where your family will be at the end of the day. And when people ask where you are from, you have a ready answer for them with lots of context and lots of details of that home. Finally, it is a safe place where you can retreat, find solitude, and care for yourself. I want to posit that what each of us has, and I presume everybody has these things, a home, meaningful relationships, making meaningful contributions to your family and your community, these are the things that every human being needs to live a life of meaning and of value and of dignity. In our advocacy for vulnerable people, whether they're older adults or people with disabilities, I don't think we talk about these fundamental issues enough. I think they can provide an invaluable tool to frame and guide our advocacy. As we saw in the video about Ms. Bunnell, it all comes down to the importance of taking a shower. A shower that gets her clean both for her health and well-being, but also for her sense of dignity as a human being, so she feels presentable to her friends and family. But the Medicare system, which is supposed to be focused on maintaining her well-being and preventing the decline of her condition, wasn't focused on either of those things. It was concerned with its bureaucratic processes. Astoundingly, it saw the taking of a shower as a convenience for her and not a necessity to her health and her dignity. But with creative and committed advocacy, Ms. Bunnell can now safely take a shower in her own home. It's a great thing. I've been litigating against human service systems for most of my legal career, so 30 years now. That experience has taught me that these systems often become incoherent. And what I mean by that is that they gradually, and some less gradually than others, lose sight of the needs of the people they purport to serve and begin to serve their own bureaucratic needs for efficiency, simplicity, cost reductions, and outcomes that are not tied in any way, shape, or form to the people they're supposed to be serving. It is a very means-ends way of thinking about things. The people served simply are the means. The outcomes, the ends, become whatever the system values. So our job as advocates is to keep our own advocacy and these human service systems, like Medicare, focused on the basic human needs of the people we and they serve. Why are these services important to this person, beyond simply treating their condition? How do they support the person to maintain their dignity? How are they part of the equation of the person maintaining meaningful relationships in their life? How do they support a person to live at home? This is why services like durable medical equipment, for example, or home health services, among many, many others, are so important. They can each provide vital care that allows a person to live at home and live a life of dignity, as Ms. Bunnell's case shows. Over the last 40 years, the Center for Medicare Advocacy has provided relevant and potent legal advocacy to older adults and people with disabilities. Our primary mission remains how to make this big, unwieldy Medicare system accountable to the most vulnerable people it purports to serve. Litigation is one of the advocacy tools we use when the policy has broken down and the system is not responding coherently to people's needs. It's why in Jimmo versus Sebelius, we fought for Ms. Jimmo and similarly situated folks who were denied skilled care because they were no longer expected to improve. For Ms. Jimmo, this threatened her ability to live at home and maintain her health and well-being. Through the litigation efforts of CMA and its partners, we were able to enter into a settlement agreement with CMS to directly redress those practices and implement policies that are focused on maintaining a person's condition and preventing their decline, and creating real opportunities for people to maintain their lives at home with family and friends. But today, our battle lines are shifting a bit. As Medicare increasingly becomes privatized, the threat of system incoherence, I believe, grows exponentially. When corporate algorithms and profit margins dictate care, the human being that is supposed to be at the center of those systems quickly disappears. The system's desire for efficiency and cost reductions morphs into automated denials. This is why maintaining CMA's capacity and the capacity of our friends and allies and the know-how to bring system change litigation is more crucial now than ever. Our clients' stories and their basic human needs must continue to guide our legal advocacy toward remedies that are both relevant and potent. We must continue to present the human story in the face of an efficient and dehumanizing system. We aren't just litigating for durable medical equipment. We're fighting for Cara Bunnell's right to feel clean and to preserve her dignity and independence. We aren't just litigating for home health services. We're protecting a person's right to lay their head down in their own bed and in their own home tonight. It's so important. As I step into the role of litigation director, I promise you that our legal strategies will always be guided by our clients' basic human needs. We will keep pursuing remedies that are both relevant and potent, and we'll never stop forcing the systems to remember that what keeps our clients safe and well is exactly what keeps all of us safe and well: a place to call home, a community to belong to, and the preservation of basic human dignity. Thank you. Snuck up on me there. Before I turn it over to Scott, I just want to take a brief moment to recognize some of our incredible sponsors for making the summit possible: the American Medical Rehabilitation Providers Association, the Gerontological Society of America, the National Committee to Preserve Social Security and Medicare, and the Consortium for Medically Necessary Oral Health Coverage. Thank you. And now I'll turn it over to Scott Perkins.
All right. Thank you, Josh. So for anybody who doesn't know, every year the Center for Medicare Advocacy staff update the Medicare Handbook, which is published through Wolters Kluwer, and we have some door prizes for folks, including in the eligible folks for door prize of a handbook are the over 1,300 people who are watching us online from all across the country. So first we have Tom Liebert. Oh, great, Tom. Yeah, you can come up.
Thank you very much.
Put that right on your bedstand so you can read before sleep every night. The next one is Ms. Randy Latham from Nucla, Colorado. So, Ms. Latham, if you're watching, you will be getting a Medicare handbook in the mail. And then last is Abdi Muhammad. Is Abdi still here? Abdi will also be getting a handbook in the mail. All right. I wanted to just take a moment and acknowledge the role of generosity in advocacy. And as I was thinking about that earlier, I remembered that I came across a Buddhist phrase when I was reading a while back that goes, generosity is the virtue that produces peace. And the generosity of individuals, foundations, colleagues, other organizations, all of our sponsors, that generosity allows advocacy organizations to move society toward peace. I think we all know the lack of peace that we have in our minds when things are difficult for us, when we are encountering obstacles, and the peace that can come when those obstacles are resolved. Ms. Burnell, when she finally was able to not have to fight, at least for a day or a week or a month, about a rolling shower chair, a peace that arises by absence of discord. And advocacy, generosity allows advocacy to do this through systemic change and by creating a more just society and increasing health and well-being for human beings. Health and well-being, as well as the other outcomes from advocacy, can also, or from systemic change and advocacy, can also provide individuals with moments of peace, just as we were noting, by just meeting their basic needs that Josh was just talking about. When those needs aren't met, there's discord and lack of peace. So we'd like to thank all of our sponsors, all of our funders, all of the individuals that support us, and in fact, all of those individuals, foundations, and organizations that support all advocacy organizations in the work they're doing in creating peace for others. Now I'd like to specifically thank the Santa Fe Group, who is our sponsor of the Chiplin Social Justice and Advocacy Award. And to tell us a little bit about that award and about Alfred J. Chiplin, for whom it was named, I'd like to invite CMA's founder, the indomitable Judy Stein, to say a few words about her friend Chip.
From Josh to David, Scott, Melanie, Pollyanna, Toby. I have to say I am so proud and relieved and grateful for the Center for Medicare Advocacy's clearly successfully moving forward happily together in our community, and the extraordinary work that David and Scott are doing in leading the organization, and in our incredible colleagues, many of whom are here and have put this together and put the community online able to be with us today. I'm so moved and proud, and thank you, Scott and David and everyone, and having a litigation director that gets teary-eyed talking about our work is the icing on the cake. So, speaking of remarkable people, Alfred J. Chiplin, I'm happy to bring his spirit to you today. Chip was a beloved and admired leader in the elder law, disability, healthcare, and civil rights communities. He was also the longtime managing attorney of the Center for Medicare Advocacy's Washington, D.C. office. And yes, we actually did have an office, and he was the manager there for many years, followed by David Lipschitz, who also managed an actual office. To honor Chip's advocacy and commitment to civility and justice for all, the Center for Medicare Advocacy established an award in his honor when he died, way too soon, in 2017. I've lost a lot of people in my life, but Chip is right up there and being with me every day. To honor Chip's advocacy and his civility, we created the Alfred J. Chiplin Jr. Social Justice and Advocacy Award to be given annually to an individual who works to advance civility in society and social justice for all, as Chip did, including during his 40-year career as an attorney. He worked tirelessly for systemic change and for countless individuals. As a key architect of the Center's ongoing commitment to ensure Medicare access for people with chronic, debilitating, and long-term conditions, his influence is still felt in everything we do. Chip brought his full humanity to the work that he loved and to our community at the Center for Medicare Advocacy. As an ordained minister, a choral singer, pianist, and poet, he graced us and the world with his light and his effervescent smile. He treated everyone he encountered with respect and kindness, even when he hadn't received that to begin with. Chip lived a full life in too short a time. He lit every room he entered. He continues to encourage us to bring more light to all our fellow humans and to work to enhance all their lives. And in his honor today, we will be honoring Dr. Natalia Chalmers, and I ask my friend and colleague, Wei Wei Kwok, to come and tell us a little bit more about that. Thank you.
Thank you, Judy. So it means so much to me to be able to honor and tell you about a cherished individual who I and many respect and admire deeply. And as you already know, this person is Dr. Natalia Chalmers. Natalia is a dentist, a scientist, a researcher, and a change leader. I once heard her say that her original mission when she started her career was to cure dental caries. I love it. I mean, she wanted to permanently end the universal scourge of cavities. So that gives you a sense of her natural inclination to tackle big challenges. And it certainly tracks with the person that I've come to know. Now, while Dr. Chalmers may not have wiped out the problem of cavities yet, She strives passionately and tirelessly to educate about the importance of oral health to overall systemic health and to find pathways for achieving equitable access to dental care because, I mean, let's face it, dental care should not be a luxury. Natalia earned her dental degree in Bulgaria at the Medical University of Sofia, where dental students are exposed to the full medical curriculum. And that's because dentistry is not segregated from medicine there the way it is here in the United States. She went on to earn a PhD in oral microbiology at the University of Maryland, completing a fellowship, her residency in pediatric dentistry. She did a clinical fellowship at the National Institute of Dental and Craniofacial Research, which is a branch of the National Institutes of Health. And there she guided the development of and secured funding for novel research and cared for medically compromised children enrolled in NIH clinical trials. Now, to gain more understanding about how big data can be used to improve delivery systems for patients, she pursued a master's degree in regulatory health science at Duke University School of Medicine. She applied this learning by lending her data and analytics expertise to a campaign led by the Maryland Dental Action Coalition to get a comprehensive adult dental benefit into that state's Medicaid program. So since 1976, Maryland had been one of those states that only covered emergency dental care for low-income adults. And Dr. Chalmers worked closely with the coalition to assess its data needs and develop policy recommendations. The data that she harnessed and analyzed revealed that the state was spending $26 million a year for ineffective emergency room visits that could have been avoided with accessible preventive dental care. And I say ineffective because emergency rooms do not generally provide dental care. They send patients home with antibiotics and painkillers. So the data also revealed that 15 people had died from complications of poor oral health, and that the counties with the highest rates of emergency department visits for dental conditions were the same counties with the highest rates of overdose deaths. Dr. Chalmers testified before the state and House, the state's House and Senate regarding this groundbreaking study. She also guided the network of stakeholders in how to leverage the cost savings data to their representatives and delegates. And, due to the efforts of this large and diverse advocacy community, the Maryland's state legislature unanimously passed a bill that mandated comprehensive dental benefits in Medicaid. And then dental care became accessible to 800,000 low-income adults. So a wonderful story about what advocacy can do. Dr. Chalmers next served as dental officer at the U.S. Food and Drug Administration. And then in 2020, she was detailed to the Centers for Medicare and Medicaid Services, where she stayed on as chief dental officer in the Office of Administrator. When she arrived at CMS, there had not been a single dentist, much less a chief dental officer, employed there since esteemed dentist Dr. Lynn Mouden retired from the post in 2017. So, oral health was largely absent from the conversation and culture at CMS at that time, and it didn't factor into policy considerations. But Dr. Chalmers set about promptly to change that by presenting to her colleagues factual evidence on how oral and dental infections can complicate the management of chronic and major health conditions like diabetes, kidney disease, and cancers. and she highlighted compelling research and data showing that appropriate dental care can improve clinical outcomes and reduce costs. The first time I met Dr. Chalmers, I was immediately taken by her warm, energetic, and down-to-earth personality, as well as her clear commitment to advancing health and eliminating disparities. At that meeting, she described how CMS was engaging with a wide range of stakeholders, including clinicians, researchers, patient advocates, and insurance leaders, to understand the landscape of medically necessary dental care and to chart a thoughtful path forward. Now, what stayed with me from that conversation was her instinct to bring all perspectives to the table and her conviction that good policy is grounded in good data. Well, fast forward to a year later in 2021, when the door closed to include a full Medicare dental benefit in the Inflation Reduction Act. Suddenly a window of opportunity opened for advocates to press for medically necessary dental coverage. At this inflection point, CMS leadership invited us to host a series of listening sessions for them to hear from and engage with stakeholders about what constitutes medically necessary dental care. And shortly after that, in 2022, the agency proposed and finalized a rule clarifying that Medicare payment is available to dental services that are integral to certain medical services. And that applies also to people enrolled in Medicare Advantage. CMS specified that Medicare would pay for services to diagnose and treat dental and oral infections in patients who need solid organ, stem cell, and bone marrow transplants, as well as heart valve procedures. And later on, the agency also recognized payment for dental care needed by patients undergoing certain cancer treatments and people receiving dialysis for end-stage kidney disease. These were landmark achievements that very likely would not have happened without Dr. Chalmers' leadership. Advocates were celebrating these victories, but Dr. Chalmers knew that they were just the first step, and that the architecture and competencies needed to implement this coverage would have to be created so that beneficiaries could actually benefit from it. As a dentist, she knew that most dental providers have no experience with using medical diagnosis codes, submitting medical claim forms, or just billing Medicare. So this was a problem because, she knew that the process had to work for dentists if it was going to work for patients. And among the solutions that she came up with was to develop Medicare's first dental claim form that was intuitive to dentists. And, launching this new form, was a formidable task that involved pushing through agency hierarchies, defending funding and staffing requests, assembling a dedicated team, building trust, and more. But thanks in great part to Dr. Chalmers' vision and determination, dentists can now successfully get reimbursed for furnishing this very important care to Medicare patients. So, it really pains me to tell you that there are currently forces at play which may threaten to roll back this progress and the investments that have been made in Medicare's dental coverage. If that should happen, we will absolutely fight to defend that coverage. So, that could be a story for another day. Hopefully it won't have to be. But today is a fitting day to recognize Dr. Chalmers and the impactful contributions she's made to improve Medicare and Medicaid for current and future generations. Natalia, where are you? Natalia, hold on. Yeah. Natalia. Thank you for your wise, compassionate, and strategic leadership.
And, you know, I know it's been your guiding truth that dental care is essential health care. And, you know, blessedly, it's been your aim to ensure access to oral health care for those who need it the most. And I just know, I just, you know, think Chip's heart would be filled with joy to know that you were receiving this award in his name. Thank you.
Thank you. I think this space has some tearing gas. A few months ago, I'll tell you a story. A few months ago, I was sitting on the top of a mountain I had no business standing on. I had never skied, okay, day in my life. The conditions are perfect, brilliant blue sky day, and there was, as they say, only one way down. Learn how to ski. At that moment, at that exact moment, with the wind in my face and, you know, the valley below, my phone rang. It was Wewe. It was Wewe calling me to tell me about this award. I've been thinking about that moment ever since, because so much of this work has felt exactly like that. You find yourself somewhere you did not entirely plan to be. There is one way forward, the sky is clear, and there is always good people by your side. And that honestly is how the rest of it went. I'm a pediatric dentist, as you heard, and a scientist. But when I arrived at CMS, I had never read, written, or edited a federal rule. That happened. I had never sat across the table full of engineers building a claim systems. I can tell you that is a long story for another day. Or our lawyers who were drafting the regulatory language around any of these changes and what we needed to do. Or the policy experts we had to work together and pin down the implementation challenges that Wewe talked about. But I knew who I was working for. That I knew, the American people. And so we did. We learned the way you learn how to ski from the top of the mountain, and that there is only one way forward. I want to honor Chip. I didn't know him personally, but from what I've heard, he sounds like an amazing person and inspiration to have known. I was so moved to read his poetry, and it's actually in your program, but I also feel the fingerprints of what he's done has stayed with us, right? The handbook is one great example that started during his tenure. And so the poem that's in your program says, when you consider the sky, here's the sky, reach with all you have, give your very best, and taste your dreams. Love this. I cannot think of those lines without going back to that mountain, and that morning on the mountain. And we don't always choose when the skies opens up. But we do choose what we do when that happens. And Chip, it sounds that he chose every day to show his finest, to bring the best. And so to receive this honor in his name is humbling in truest of sense. So thank you. I have received many recognitions in my career, but this one feels different because it's named after an advocate. It's given by an advocate organization. And the work is of service to beneficiaries who too often have no one to represent them in the rooms where decisions are being made. So to be recognized in that framework alongside with the people in this room is truly an honor and means more than I could say. I want to thank the Centers for Medicare Advocacy. In Washington, we're here. We know it's easy to confuse motion with progress. There's a lot of motion, not a lot of progress. But this center, I think, is doing something rare because you are able to do this unglamorous, decades-long work. This has been in work in the decades, right, to move and work for the advocates, for the beneficiaries. to ensuring that what is promised on paper is actually delivered to the patients. And that requires a lot of discipline and dedication and commitment. And none of this work, none of my work, none of other work is possible, the work we're honoring tonight, without a team of people who show up every day in service to someone else. We're fortunate when we land somewhere where such people gather. And if I may, I would like to redirect the credit where it belongs. The recognition belongs to a much larger community of advocates. First, the patients who've told us their stories to me as a clinician. The advocates, and we see here the Santa Fe group has done a lot of work, obviously the Center for Medicare Advocacy, and others. The clinicians who take care of the patients and told me the stories of how their patients suffered the terrible consequences of poor oral health when they had to start treatment for acute leukemia and they couldn't. And a nurse, I never forget this, after we published the chemotherapy treatment, came to me and said, if this has happened 5 years ago, my patient would be alive today. It really is that impactful. So the credit belongs to the clinicians, the researchers who gathered the evidence, and also my colleagues at the Centers for Medicare and Medicaid Services, who work alongside me to make sure that oral health had a real part in the conversation around overall health, chronic disease, and management. We still have a long way to go, but moments like this remind us how far we've come together. I've learned that advocacy is fundamentally about maintaining vigilance for those who cannot be present in these rooms, for the Medicare beneficiary navigating a transplant evaluation, or dialysis patient whose dental infection went untreated, or the family that is trying to make sense of their denial letter. They're those who this work is for. They're who I carry with me in every meeting, when I look at every data, and I look at a lot of data, every policy memo. And they're who I will keep showing up for, and I think we all show up for. I was given early in my life a way of seeing this work, and that has never left me, that the highest thing any of us can do is to be of service to others. And that work done in that spirit can be worship. I wonder, I suspect Chip had some of that in him, knowing what he did, what he's done. And that conviction really is important because it can reorient us when the politics get small. I also want to acknowledge what so many of you already know. The gains we made have just begun. Dentists are still trying to figure out how to deal and bill for this. Patients are still learning that there is such coverage. This architecture is young, and young things are fragile. So I accept this award, not as a closing chapter, but as a charge. The work of integrating oral health into the rest of healthcare, of insisting that in policy and practice, the mouth is part of the body, is not finished. I would say it's just begun. I'm committed to that work today, and whatever role I'm asked to play, and as long as it takes. And I will end with, to my family, who have carried more than their share, to my colleagues at NIH, FDA, and CMS, and now at Overjet, who trusted me with hard problems. To everyone in this room, and there are a lot of friends and colleagues, who taught me that what advocacy actually looks like. Thank you. Chip asked us to consider the sky and how we show up every day. That morning on the mountain, I made it down. Wasn't very graceful, but I made it down. Because people who knew what they were doing skied beside me, called out the turns, and waited where the slope got really steep. The work ahead, I would say, is a longer descent on a harder terrain. But the principle holds. Forward only, clear skies, good people on your side. So the sky's still open, and let's not waste it. Thank you so much. What an honor. Yes. Oh, thank you so much. There it is. Oh my God. Thank you.
Dr. Chalmers, it's an honor to present you with the Alfred J. Chiplin Jr. Award.
Thank you.
And for everyone, it reads, presented to Dr. Natalia Chalmers in recognition of her dedication and advocacy to achieve greater equity in oral health care access, quality, and outcomes.
Thank you so much. Thank you.
Thank you.
Thank you.
Thank you for being with us.
Beautiful. Thank you. Yes, yes, you may. Thank you so much.
Thank you, Terry.
Thank you all. Thank you.
There you go. And with that, I'd like to thank everybody here. I'd like to thank our presenters, our awardees, our attendees in this room, our 1,300 attendees from around the country watching from their homes or offices, and the hundreds that will be watching this on YouTube once it's posted, as well as the folks in this room and our sponsors. So thank you, and we look forward to seeing you next year.